All right, we're gonna record. For some reason, the streaming isn't working. We'll just record it and I'll upload the video tomorrow. But you're ready to go.
All right, good evening, everyone. Welcome to Health, Housing, and Human Services. This is our monthly meeting, our meeting for September 2025. I got that right this time. And I am co-chair Maria Ortiz. This is my co-chair Joe Restuccia. As a reminder to Housing, Health, and Human Services, HHS members, CB4 has a hybrid meeting policy. And if we need an in-person quorum, and if you are online, you need to have your camera on. This meeting is being recorded on YouTube where it will live forever. To the attendees of the meeting, you can sign up on the CB4 website to receive updates about meetings, events in the community, be on the listserv. If this is your first meeting, normally what we do is we have a presentation given by some group, and then questions and comments are delivered by CB4 members of the committee. And then we go to attendees in the public, and then we come back to committee. And sometimes what we do is we vote on a letter that goes to our next full board meeting where we have a final vote for it. And anything else that's important to know? Usually what we also do is go around the room and introduce ourselves. The CB4 members will start with Rachel Lee, committee member. Maria Ortiz.
Joe Restuccia, co-chair.
Kevin Collins, member.
Katie Savage, member.
Pete Diaz, member.
Liam Buckley, member. Brian Sloan, member.
We will go to Rachel, Roberta.
Hi, Roberta Barnett, committee member.
Matthew Klein, committee member.
Brian Weber, public attendee.
Oh, I thought you got the.
John Nolan, member.
And then from the public,
Health and Hospitals.
Laura, that's weird hospitals.
oh, and
Oh
sorry,
my God, thank you.
Hector Vasquez online.
Oh, I can't hear
Your
you.
sound's not working, Hector.
Video.
No, yeah, you're unmuted, but there's no sound coming through.
So we have Hector Vasquez, who's also a CB4 member. Sometimes I forget to go online to the folks there. Apologies, Hector. Oh. Can you speak up? Maybe it's working now.
Hector says to say something? No,
Oh.
no, it's not working, not working.
Okay.
So then, attendees from the public?
Patrick O'Neill, public attendee, I also work for SL, so here to just learn more about your guys' process.
Maya Post Housing, Clinton Housing Development Company.
Carl Wilson, who's also a member, Eric Munster.
Jason Hensman, New York City Health and Hospitals.
Brian Weber.
Still Brian Weber, West Coast Street Block Association, Midtown South Precinct Council.
Chris Keeley, Health and Hospitals.
So we have a full complement. So we have three items on our agenda tonight. First one, 442 West 46th Street, a presentation by Housing Hospitals, known as HHC, about a medical facility / shelter to make it easier to understand at 442 West 36th Street. Our next item about West 49th Street and the enforcement conditions there, 308, 310, 318 to 340 West 49th Street. If that's been postponed to October for the availability of the owner. And then we'll have a community discussion about our 2027 statement of district needs that you do every year. So let's first just frame where we are with the project and then have them do a presentation. We have after presentation, correct? So.
Yes, he's gonna be driving it.
Let me try it. So, building 442 West 36th Street is a budget hotel on West 36th between Dyer and 10th Avenues. The community board was informed in August that there would be.
July.
June, July. The
Well-
end of June, early July.
We met in July. We had a.
We met in July, right?
July 3rd.
July 3rd, right. Okay, so end of June, beginning of July, that there was a facility that was supposed to be opened. It was at the point that we met, it was already decided, it was moving ahead. Lots of concerns were raised about, we'll talk about those tonight. At the same time, there was another facility that has been opened that was not disclosed to the community board, irrespective of what DHS says, because I can get the notices. Right across the street at the Casa Hotel. That is a family shelter, which we were not informed about. So in a very short period of time, we had two different homeless shelters / facilities opening across the street from one another. There was a walkthrough on, tell me the date.
We can look up.
So I heard-
Early August or late.
Early August, organized by our elected officials and the community board with all the folks from HHC, walking around seeing neighborhood conditions, what was there, and really being very forceful on the part of our elected officials that this program, as was explained to us more and more, the program itself made a lot of sense, but it's the location. That was the big question back and forth. So we went through this a lot, and now we left with the understanding that HHC brought this to their board in July. Hold on a second. I brought this to their board in July, and it was approved to be leased. That's correct? Right, and we left with that, from that tour that it was a year lease, but we since understood that it's a 3-year lease. Is that incorrect?
Okay, so you want to go to specific?
Just the general, I learned.
Or it's a 3-year lease with options to extend up to 5 and termination provision, so if we need to leave early, we.
Right. And this is a new program which they will discuss and present tonight. I expect there to be a healthy discussion and debate about it, as always is, on these things. But I do want to note again, we were not given any long-term advance notification of the intention for this to happen. And we learned in our tour that it was taken from Department of Homeless Services list, which we didn't know existed until that point in time, of various locations. And the criteria was that it had to be close to Bellevue. And it had to be of a certain size for the scale to work. I will tell you that the tour was attended by about 20 people, 25 people at least. Everyone felt very confident that number one, as this board has noted, that HHC managing facilities is the world of difference from DHS, where we have all sorts of issues and problems. Those of us who were on the board during COVID, remember we toured the Watson Hotel on 57th Street, and compared to the other hotels being managed by DHS, this was the stellar level. And I said this publicly, and I said it on Zoom meetings, and I said it to tour folks, no question. And it's not about the question. And the second part is that our board has advocated for a long time. We need a different level of facility for folks who are chronically and persistently mentally ill, especially if we have a substance abuse and alcohol abuse problem, because they are not suitable for independent supportive housing. They're not, period. They don't succeed there, it's just a revolving door. So we were in agreement that good operator as things go, and then the need for the program as things go, but the location was an absolute wrong decision. And we went back and forth, and they moved ahead. So that's where we are today.
Joe, one clarification. Did the board notify about either of these?
For the DHS hotel, the DHS claims they notified us. We have no record of notification. Okay, for this one.
Can I-
And Jesse
Can
wants
I clarify
Yeah.
that one thing?
Jesse, go ahead, please.
Two different pieces of information. Just one regarding the DHS shelter. It took us some time to track down. It was considered temporary, and that is the notification process is extremely less arduous. For a regular standard permanent shelter, they have to notify us. They have to have a committee meeting. During that period in time, as 2023, we did find the notification email. It was a single email, no more information, no more meeting with the provider. So I just want to be clear on that. There was an email sent back in 2023 for this family shelter. That's not which is what Health and Hospitals is presenting on tonight. And then the other thing I just wanted to clarify, because I just got it into the Dropbox. As you all know, on the committee, we have a social service provider checklist. We had sent that to Health and Hospitals. They completed it. They sent it to us today. We got it into the Dropbox, so it wasn't in there yesterday. I do apologize about that. And it also has a number of other, sorry, my son is in the background there, if you hear him yelling. There's a number of other documents they provided. So those are all in the Dropbox as of today. So I just wanted to make sure people are aware, and it's not surprising to you.
But I want to note for the record that the DHS shelter was never fully used by DHS. There were some rooms that were being used, and then almost concurrently with your announcement, there was a notice posted on the door, which Brian Weber brought to our attention, that says the hotel is now closed, it's DHS only. And it's not unusual for there to be certain rooms or blocks of rooms rented in hotels, happens all the time in our district, but not to close it entirely. And it's gone from sort of emergency to permanent, and in fact, our board notified HHC of the existence of this thing. It was not necessarily, they were, I was on a call where they were not aware of it.
I think the confusion on that call was that it seemed like there were multiple sites being brought to our attention on that block, whereas there's one site. So just to
No,
clarify.
no, I was on the call.
So was I.
I notified,
remember it.
and everyone said, one
I
shelter,
think we understood you to be saying there was a new shelter opening as opposed to one currently existing. That was the confusion.
I'm gonna say
So it
again,
was
Yeah, that's what I
additive
thought,
as
but
opposed
One
to,
was being open.
right.
right,
And
so,
what we have understood, we had understood from DHS was there was something already operational, so that was where the confusion.
right, I was gonna say in general, we prefer not to rewrite history. We sat and had a discussion about it. There was shock and surprise by HHC, because they were not aware that the shelter operating. And that's where we left it, all right? Here's what's important, is that you have a community board who has said up front that it wants this type of facility in its district. You don't get that very often. We are the board, and this committee is the group that proposed the conversion of Bayview, former women's prison on West 20th Street and 11th Avenue, to include beds for severely mentally ill who cannot be alone, who cannot really succeed in supportive housing. We pushed that very sincerely with the State Office of Low Reach. So that's not our issue at all. Our issue is the management of how social services are cited in an equitable and thoughtful way, and there's real planning for it, as opposed to an opportunistic way. DHS has a list, gives you a hotel, you say that's what it fits, we do it, another facility is there, right? So we'll talk, and I really appreciate it, you don't defend, as more like just discuss what's happening here, that we have a long history in our board, unfortunately, of the DHS not communicating effectively in advance and engaging with this board, which is very open and welcoming. And therefore, it has created the backlash that the board frequently has to deal with in management from block associations and neighbors and neighboring institutions. So that's the thing we have to manage. It's not about, it's the bad process, right?
And we're not trying to defend. I think there's a lot of folks here who weren't a part of the conversations during the summer. So I want to make sure that people are brought in. We want to make sure that we can show the presentation for those who don't know what the program is yet.
Right, that's what we're gonna do, but again, I'm gonna ask you to dial down the defensive part of it. It's not even needed, because we're at a point now where you're opening a facility, we're engaging with it, right? And we are not necessarily going to be fully happy and embrace it. We want to hear about it, understand it, and then figure out how to make it work. And you also noted in the tour that you've never done this before. I think that's a key thing for everyone to know. It's a new model, not a bad model, it's a new model. And they have the ability to exit if it's not working, and they're gonna scale it up too. So I want to turn that over. Who's gonna make the presentation?
Me, well, you have a lot of us here, so
Right, well,
we
you know,
all
it's
cover
kind of clear,
different things.
might be helpful though, it'd be helpful from health hospitals, say what your roles are, because no one, I know that, but if you can start out, just go around the room again.
Sure. Laura Atlas, Assistant Vice President of Government Affairs.
Hi, Dina Montes, External Affairs and Community Affairs.
Hi, I'm Omar Fattah, the Youth for Behavioral Health Services at H&H.
Chris Keeley, Chief Operating Officer for Ambulatory Care, and you mentioned the Watson Hotel, I was the Chief Operating Officer for that program.
Jason Hanson, I'm the Senior Advisor for Behavioral Health Policy and Communications.
You're gonna have to move behind it, from behind the column, because no one can see you on the line.
The owl can't go.
So do you guys want us to there for?
Yeah,
You know, we can go up to this.
no, it's not gonna, it's not gonna work. If you want to step up a little bit, you should. Yeah.
Okay.
If you guys.
I just want to
Yes.
keep it wind up, just like
If we could just have one or two more at the table, Omar, you would be good to
Yeah.
have at the table.
And you
Right.
guys were present. Sorry. And thank you so much, members, for flipping around. Again, and the first thing is, for, just to clarify for all the committee members of the public, just to give a sort of what HHD is.
Oh,
Yeah,
fantastic.
start
Well,
with
that's how the presentation begins,
Right.
so
I'm saying, yeah.
we are alive, so.
You gotta always try to kill the acronyms and start together.
Sure. No, that's exactly where we begin, is by situating health hospitals. And so Jesse is gonna be driving, he's
Yeah.
gonna set up But what you'll see in the beginning of, just to give folks a kind of table of contents. In the beginning, we're gonna talk about health and hospitals, we're gonna talk about our behavioral health services. Some of this you may know, some of this you may not. And then we will talk about the program itself, kind of its inception, how we've come to this point, and then what to expect once it opens.
Jesse, could you close the participants on the side so the screen gets bigger, the display gets bigger?
Before we.
We can do that.
I'm dying to ask you guys a question. How do you do the camera thing?
Oh my God, sorry.
This is so in here.
This is this viral thing and we got them and they work.
Oh my God.
The only problem is when a lot of people are debating,
Here,
it's a little bit, Omar, and a lot of people are talking fast, it's a little bit disorienting.
It does.
Can you guys, yeah, give me 1 second. I'm just having some slight technical difficulties trying to get it to the.
Better than yesterday evening for the board members that we were at Mount Sinai,
Oh, really?
internet cut out that time.
Oh,
Wow.
It'll be-
We have,
We don't.
we have our own Mount Sinai issues.
Right now,
It's the internet.
have snacks if you want some from the table.
Yeah. Oh, I'm good. We have the Q and A too, yeah. Yeah, so we have shared this, and I know Jesse, I think, put it into the Dropbox, but we also brought hard copies of the FAQs, just so folks can take in the information as well. It's available online, but you know, we just wanted to come with as much information as we could for you all.
And we made 12 copies, so apologies if there's not enough, but this is available online, so I can email you, and again, it's also in the Dropbox.
Oh, I have it online.
We're waiting if he's working on it.
Oh.
You can see the focus.
I won't put we had everyone visually and no voice.
Oh.
And then we had everyone,
Disembodied.
no voices.
Yeah, yeah.
This was like,
Well, you know, we use WebEx, which is,
yeah, but in the.
nobody else can use.
But in the
Uh,
middle.
is this better, guys?
That's great.
There we go.
There we go. All right, got it.
All right,
Uh,
let's get started.
Next, yeah.
Okay, so health and hospitals, you know, you guys probably know Bellevue. We have 11 other acute hospitals as well. We also operate roughly over 30 ambulatory centers. We have over 45,000 staff. We run long-term care facilities. We run correctional health services for New York. So to say that we serve a lot of New Yorkers and that we employ a lot of New Yorkers is, you know, both accurate and an understatement. Every year we're seeing roughly 1 million New Yorkers. So if you think about that, you know, there's 8.5 or so million New Yorkers. We're seeing a lot of them. We know a lot about them. You can read more about the demographics of who we're serving, but we really specifically wanted to talk to you today about our behavioral health services. So when Joe says this is new, he is correct in some ways. And in other ways, I'd add a little nuance to it, which is to say, because we are working with so many patients who are receiving behavioral health services from us constantly, we know a lot about them, about their needs, about where the system is not meeting them, and about how we can kind of complete the options available to them so that they aren't continuously cycling through our system.
Can you start even further back for a moment, explain the
Yes.
nature of health and hospitals, sub corporation, that kind of stuff.
Oh, well,
That's
so
the age, so
New York
understand.
City Health and Hospitals is the oldest public hospital system in the country. And actually Bellevue actually is older than New York City itself. Not by a huge amount, but a little bragging. And is also the largest public hospital system in the country. We're incredibly proud of the work that we do. We will treat anybody. That is our mission. You know, no questions asked, status, insurance. That is not a part of kind of the ethics of working for health and hospitals. That is not a part of the mission. We are really here to say, who are all of the folks who have not been able to access resources throughout the other medical providers in the city, and what can we do when they get to us to try to get them enrolled in Medicare, in Medicaid or Medicare, through Metro Health Plus, through NYC Care, for correctional health services. Correctional health services provides a tremendous amount of medical services in New York City. For many people, that will be the first time seeing a doctor when they're in custody in decades. So in any way that you can kind of imagine where folks are vulnerable, where folks are disconnected from medical care, H&H is stepping in. In terms of H&H being a corporation, we are a semi-private, a lawyer will hate what I'm saying about this. We are a semi-private corporation, or a private-public corporation is what I should say.
Public benefit corporation?
No, we're a private, I think it's
Private
technically
public.
private-public, we're a 501, something with a C on the end of it. So we have a board, our CEO, Dr. Katz, sits at the head, with the president of the board. And so items will go before the board of all different varieties, procurement, services, to both kind of understand the system, expand the system, see if we're putting resources into the right place. And so, when Joe mentions this going before a board, what he means is the lease was brought to a committee, much like the way a community board works, brought to the committee and then brought to a full board to sort of understand how this is serving the system and the city.
It's like a city agency at arm's length, the separate governance structure, which is
Exactly.
very important to understand, that it's not just the mayor saying this is that, it's a broader thing.
Yeah, and there's a lot of distinctions we're gonna talk about, that distinguish New York City Health and Hospitals from other agencies that I think may be new to folks, and so I really do wanna spend time on that, even though it's not specific
It's
to.
funded by city government, it's funded by the city.
So, like any other.
Each and each, or which?
H&H.
H&H. So like any other hospital system, you know, when patients come in, if they have insurance, we will bill, so we can generate revenue. But we are not in this for revenue. So, you know, we certainly do get money from the city, we get money from the state, we get money from the federal government.
We have Medicare and Medicaid
indeed,
billing. all that
indeed.
shit.
And, you know, a part of all of the kind of grants that you hear about, we are all sort of in that pool. We can go to the next slide. Jesse.
Next slide.
All right, I'm gonna hand it over to.
Yeah, so focusing on behavioral health, so Laura mentioned that we are the largest municipal healthcare system in the US. Here in New York City, we're the largest provider of behavioral health services. So we see almost 80,000 people a year in our behavioral health services. That's both mental health and substance use care. And we basically have the whole continuum of care. So this is a little bit small on the slide, you can see it. But if you look at the left lower corner, these are our crisis services. So this includes mobile crisis teams that respond if you call 988. But we also run the BHER team in partnership with FDNY. These are the teams of social workers and EMS workers that respond to 911 mental health calls. So we oversee that program. Actually, Jason sitting next to me was one of the people who started this program for the city. And then you move on to emergency department. All the people who are brought in are first seen in our emergency departments. And we have CPAPs in almost all our facilities, and these are more larger ERs, basically, because they have beds where you can observe people and they have mobile crisis teams attached to them. And then we have our inpatient services. Not everyone seen in the ED ends up being admitted to inpatient, but a significant number of people end up admitted to inpatient. We have the whole array of inpatient services, adult, child. We have the only forensic units in New York City, both for men and women. And as I mentioned, we have adult and child as well. And then ultimately our outpatient program. So we see almost 8,000 visits a year in our outpatient departments. This includes mental health for adults, children, substance use care, and it includes different levels of care, whether it's a regular clinic or an intensive outpatient program.
800,000?
800,000.
You said 8,000.
800,000.
Yeah. For that, I know.
You know, at H&H, everything is in the thousands.
Hundreds.
And then, as you can see, the foundation for all of this is care management. We have many different programs for care management, including our Health Home Plus, and our critical time intervention teams. These are all different forms of rapid services that we give to patients when they leave our inpatient units or ERs, or if they are enrolled in our outpatient clinics, to make sure that they're able to be supported in the community. Why am I telling you all of this? For two reasons. One, to show you that what we don't have right now, what's missing from our continuum of care, is, as Joe mentioned earlier, a step-down program, a place where we can discharge people. We hear a lot about the revolving door, and that's something that people complain about a lot, that people are brought to us, we treat them, we stabilize them, but then what do? We release them back to the city, because we don't have options. Where are we gonna send them? And we all know that the DHS system is here to serve a very important purpose, but there are people who need a higher level. Not everyone is served by the DHS system. So we're missing this one model or this one program to fill in that continuum.
That's a significant one.
Significant.
We identified over and over.
It's huge. And I can attest to that personally, because I worked on inpatient for many, many years, and I wish that we had this program many years ago. It's just like patients know it, we know it. The second reason why we're showing all of this is to go back to Laura's point, is we are different. And again, I'm not throwing the issues under the bus in any way, but we are different in the sense that this program would be part of our family of programs. So if you are part of Bridge to Home, even though we've never run something like Bridge to Home before, but we run all of this. And we have a transfer center that has actually ambulances where we can transport people. If someone has an emergency, we don't even have to call 911. We can actually have our own ambulances come pick them up, bring them to H&H to be admitted. We have a 24/7 online urgent service that anyone can use actually, by the way, and this is open to the public, telehealth. So if you're at Bridge to Home and you need to talk to someone at 2 a.m. on a Sunday, you can call Express Care and you can see someone. So we have all these different components. We have safety net clinics. These are clinics that are outpatient, but they're primary care clinics, but they also have behavioral services. So if you need outpatient care, we can refer you to. So we hear this a lot from the community, people saying, I can't get an appointment, I have to wait 6 months. We don't have that problem because we have the clinics ourselves, and if someone needs an appointment, we can see them the next day. So that's the, importance of having the whole continuum and fitting Bridge to Home inside our existing continuum.
And by the way, the telehealth service is available to anybody. Anyone, that you know in your lives is looking for mental health, emergency mental health services, needs them, and it's late at night and they don't wanna go, you don't wanna go to the hospital or call 911. What Omar is talking about is not explicit for the folks in this program. That is available to all.
And it's called Express Care, so you just have to Google it, literally, Express Care, and you will find it. And we'll talk more in a minute, but also the one huge advantage about this program is that everyone employed by this program is an H&H employee. So they're gonna have our badge, and they're gonna be using the exact same medical record system that we use at H&H. So if someone is in this program, they end up in the ER, there's no miscommunication, we can just go in, find out everything that's happening with them. And if a staff member from Bridge to Home wants to go with a patient or they want to visit them, they can just walk right in because they have the ID and no one is going to stop them.
And something Omar has really taught me in this work is what happens is you've stabilized a patient, they're ready for discharge, you've started to work on a supportive housing application with them even. And as soon as they're discharged, you can't find them again, either because they've been discharged to a facility where they're no longer in our system, and therefore we can't communicate back and forth because of privacy reasons, or they've gone back to the street and we don't know where they are. So this program is really looking to focus on that particular challenge as well.
Next slide.
So this is just to make the connection between home, and I don't want to preach to the choir, you probably already know this, but I just want to give some numbers to it and some highlight. Exactly, everyone lives in New York knows this, the connection between homelessness and mental illness. So that 50% is the magic number, so almost 50% of people who are homeless experience severe mental illness, and the other way is true for us, for H&H. 50% of our patients with behavioral problems are homeless, so there's a connection there. And we know from our own data and from studies that were done as well, that if you are homeless, that factor in and of itself makes you more likely to utilize AEDs, more likely to utilize inpatient care, both medicine and behavioral health. So we are addressing homelessness in and of itself as a problem. And as Laura mentioned, we need a place for people to stay. It's a very practical thing. We give people medications, when we discharge them out on the street, where are they going to keep it? There's literally no place to keep their medications. So you need a place to, function, but also you need some degree of structure. If you have severe mental illness, you're barely able to function, you're barely able to take care of yourself. Living out on the street or in the shelter system is very hard to navigate. So this program gives them a private room where they're able to live in it and receive treatment, and allows us to work with them on their housing application. So we can get them into permanent housing, which is the goal. Next slide.
So this is the sort of background of how this program came to be. It was announced in January of this year. So, in terms of sort of announcement to opening, we have really been determined to open this as quickly as possible, because every day that we don't open, we see more and more of the repercussions of this. More folks who are out on the street, with mental illness, more folks who have not been able to complete or continue their stabilization, more folks who are not able to complete or continue their support housing application. And so we're gonna talk about how all of that is kind of built into this program.
Question.
Yes, go ahead.
Bullet point, how do you, so you have like of the whole city, how did you decide?
Is it okay if we pause the questions and just
okay.
write them down and have them at the end?
Sure.
Yeah, thank you.
Okay, it's your meeting.
So
Okay,
we're ready to have a lot of questions.
yeah, we're gonna do that. All right, we're gonna continue forward.
Next,
Yeah, so this is basically the model itself. So, as you can see here, it's definitely a voluntary place. So people, have to go, they have to be part of the program. They have to be willing to be there. And it's, for people with severe mental illness and experiencing homelessness. But just to highlight that people who are coming to this program are not having active severe mental illness. They're gonna be coming from H&H. They're gonna be stable. They're gonna be on their medications. They're gonna agree to coming to this program. So they're gonna be clinically stable and they're gonna be able to function in this environment. Otherwise, by definition, they won't be there and we won't put them there because we're running this program and we have an interest in making sure that people succeed. So the whole idea behind this is to really be able to support people through their housing application, which Jason will talk about in a minute. It takes up to a year, believe it or not, to get someone into permanent housing. What's been happening now, as Laura mentioned, is because of this not being able to find people, you start the process, you lose the patient, 3 months go by, then you have to go back to the beginning. It's a nightmare to get someone into housing. So we just need them to be somewhere for long enough to finish that process and be able to be giving them treatment during that time so they don't decompensate, come back to the hospital, but also in a place for them to accept. Because right now, when I offer my patients shelter, they already know what the shelter is. They know it more than any of us. And they say, no, I don't want to go and be in a room with 100 other people. But if you say, I'm gonna give you a private room, our theory is that people are gonna accept that because people tell us, I want a private room. So that program is going to address that. There's gonna be 24/7 staffing, and we'll talk about the staffing in a second. So even though it's a home-like environment, but we're gonna have treatment outside. So we're used to the idea of people going to treatment. But unfortunately, what we see in this population is people don't do it, right? They refuse to go or they don't follow up. So we're gonna bring the treatment to them, literally to where they live, not inside their rooms, but in the building. And the treatment is gonna have, and we'll go over the details in a second, but it will have, a social worker, a psychiatrist, but also it's gonna have 24/7 presence of a nurse, of a psych tech, which is a nursing support person, and security obviously, so that we can manage the environment and make sure that it's safe for people living there and staff and the community.
So I wanted to also pause here and go back to something that Joe has spoken about in terms of providers and the distinction between DHS and H&H here. So you guys are used to DHS coming, DHS will say, this is the provider, they have a contract with us, they'll be running the site, please, direct questions to them. We are the actual provider here. It is not contracted out. That's what we're trying to emphasize to folks. These are H&H employees, they are in the H&H system. And we are there 24/7, our staff. So the ability to raise flags, address concerns, hopefully create resolutions is much more direct in our system. That's something that was true in the HERCs as well. So really important, I think, to understand that element, and also important that unlike DHS, and DHS has a very difficult task, which is that anybody who needs placement must be placed, no matter what. We are starting with and we'll go through kind of the patient journey, but we are beginning with a clinical evaluation. And the clinical referral that comes from that evaluation will say, we believe this person, from a clinical perspective, is appropriate for this site, but we control it. It is all within our system. It is not, and Joe can, I'm sure, tell you how difficult it is when HRA is generating people and you're saying, I'm the provider, this person is not appropriate for me. And they're saying, this is the person we're getting on. We're gonna have more flexibility. We have the ability to kind of select. There are patients and we are doing the referrals also. And we also run the site. So all of those things have to mesh, right? The patient has to commit to the program voluntarily, although there is not a specific time limit. They can leave if they want to. The providers have to recommend the patient or refer the patient, and the folks on site have to say, yeah, we think they're appropriate too. So all of those are
Oh,
working.
both the sending and the receiving.
Indeed,
Okay,
indeed.
Yes. And just to, highlight that when we say we're running, we're literally running, like Chris is sitting here, like he's gonna be running, it sounds like H and H is running, so we're literally here that people are gonna be running this program. Next slide.
Next.
This is basically a typical, we kind of talked about this at the beginning, like a typical patient journey, so. For people living in the community, there's a step even before that, right? Before you're admitted to inpatient, and we've talked about this during the tour. You have someone on the street, you have someone in the park, we went and we saw it, you have someone in the subway system. We have a mechanism right now through our work with Brian Stetton in City Hall and the outreach teams and the PATH and the Scout programs. We have a mechanism to activate an involuntary removal right now, and this is happening.
Just a quick thing, so people, new committee members, Brian Stetton is the mayor's chief advisor on mental health. He's come and talked to this committee many times, and he actually participated in the tour and described like the top 50.
Yeah, exactly.
If you just mention what that.
Yeah, so and actually Jason works on this a lot, of maybe I can, you can jump in if you wanna add something, but so we are H&H, one of the agencies, we have DHS, we have HRA, we have, MTA, we work together and we have 3 calls every single week, literally for the last few years, where we maintain a list of, we call it top 50 because there's always 50 people on it. And if we need it, it could be more than that, obviously, and these are people that we keep track of literally at the city level. But also we have a mechanism to activate an involuntary removal. So if there's someone that anyone is worried about, on your street or in your neighborhood and you want them to get care, you can activate an involuntary removal through this process. And we could talk more about what this could look like for this specific block that actually Richmond is gonna be on. So what happens now with involuntary removal is people are brought into our emergency room. We do an assessment. Most of these patients end up being admitted to the hospital. So we bring them in, we stabilize them, we give them medications, excuse me. Sometimes they have medical comorbidities, someone has been covered in lice for days. They get to the point where they're so anemic, it can be medically dangerous. We give them blood transfusion. So we take care of them, we get them to a point where they're actually clinically stable. And then what happens now, unfortunately, as I mentioned earlier, now it's time for the shelter. Where do we send them? Back to the shelter, right? The shelter.
The street is not really, right.
What's that?
But frequently to the street because people refuse to go to a shelter.
Exactly, they tell us.
Yeah, right.
And we're not gonna lie, like, we don't have many options. We say, well, I don't have anything. So that's what we've been asking for this program for many years. And this is gonna interrupt that. So then now we screen them to bridge to home, as long as the patient is willing to come. Then they come, and then the team at Bridge to Home also, they can screen them and accept them and make sure they're appropriate. Then the person moves into Bridge to Home and we bring the treatment to them. So there's no interruption in treatment. And 30 days after discharge is that critical period, because when people leave the hospital, they have enough stability to last like a week or two. Sometimes we give people long-acting injections that last a month. So we have that month, but what ends up happening is that because we don't have something like Bridge to Home now, within a month, everything goes back to, and then sometimes people end up coming back. But with this, we're gonna be able to just maintain that treatment and stability and work with them on the housing process, which is the ultimate goal. This program literally is called Bridge to Home because it's literally a bridge to home. It's not meant to be a place where people live forever. And then we'll switch to permanent housing. One other thing to add to this is that this is connected to our continuum of care. We do have units now in our system called extended care units where people can stay for up to 120 days. So we have those units now, but they have
In the hospital.
in the hospital. Yeah. On West 30th Street, but we have one at Bellevue, one at Kings, and one at Elmhurst. And the problem with those units is we have around 20 beds. So
20?
around 20 beds.
Yeah.
We'll just,
At
yeah,
each site?
At each site.
so like 60 for the city of New York.
Exactly. So by having this program and programs like it, we're able to move people out sooner from those units and bring in more people to even those units as well, right? So we're kind of not only increasing this capacity, but we're increasing the capacity and the throughput for the whole system. So I'm gonna pass it to Jason to talk more about the housing journey and why does it take a whole year to get someone into housing and how we're gonna get just in it.
Right, so the housing process, as Omar mentioned, can take upwards of a year, so I'm not gonna go through every single step on the right-hand side, but I'm gonna focus in on a couple of steps, and one of those steps I wanna focus in on is that second step, and that's the mental health report. So what often happens is when someone is discharged into shelter or into the street, that mental health report is a very elusive thing. To have someone that knows that patient well enough to do that mental health report in the community, that can take upwards of 6 months and up to 6, 7, 8, 9, 10 times to get that done. What we're trying to do here is again, close that gap in between all of these parts of the process, right? And making sure that we have people that know these patients incredibly well. We're also gonna be leveraging our existing programming. On top of all the things that Omar mentioned, we have a Housing for Health team that has literally housed thousands of individuals within the health and hospital system in permanent supportive housing. So we're gonna be leveraging that program and their housing location and placement services to really match our patients with apartments, so with this supportive housing. And really rapidly go through what is a pretty lengthy process as fast as, not as fast as we can, but as fast as the patient is currently stable, right? So we're trying to do both. We're trying to keep the patient stable, but also find them the right place in the community. And this is gonna give us that time that we don't have on our inpatient units, even in our ECUs, to find the right place for the individuals to be living in the community. Again, it is a very lengthy process. My background actually is at DHS very early on, and trying to help the shelters kind of manage, and the mental health shelters in particular, manage this very lengthy process, which can take really up to a year, so.
And I do want to talk briefly about housing for health. I know it's not a particular topic here, but I think what's important about that is that's a spectrum of programs meant to connect our patients to supportive and permanent housing. Some of that housing is actually on H&H campuses.
Yeah.
So for instance, the Queen's Hospital has a newish building that they've just turned into supportive and affordable housing called the T building. So we're not asking you guys to sort of take on a responsibility that we ourselves are not also being responsive to. We think this is one of the most important challenges our patients are seeing is instability, and we know it because they're essentially living in the extended care units because they don't have a place to go. So, you know, if folks are interested in hearing more about our housing programs, I'm more than happy to talk about that as well at a different time.
Next slide.
Yeah, next time.
Okay, so this gets, I think this is maybe what you were gonna ask about in terms of location. So when we were seeking locations, we knew that we were gonna need a site that was proximate to Bellevue. You know, I don't think anybody believed it was gonna be within 2 blocks of Bellevue or anything like that, but within reasonable distance, so that when patients are discharged, they can go to the site. It's not going to be that much of a burden for them to travel there, and vice versa, if they need to go back to H&H, it's not going to be so burdensome. We also know that our maximum capacity was gonna be about 50 people. So this site itself has 56 units, 46 of them will be for guests. So we're
Can I
talking
ask
about,
a question here?
Yeah.
I know we all do this, but there comes a point that reality's got to be true. You say guests, they're patients or they're clients.
they're patients, I
Right,
mean,
and I think it's important in general presentations, it creates a euphemism that is not accurate. You're really working in a clinical manner with patients and clients.
Sure.
Well, if you just present it that way, it's clearer.
And just one piece I wanna add on that, I agree with the sentiment there. The way I think about it, for what it's worth, is there's 46 guests in 46 guest rooms. And then they come to get care at those clinical spaces within the building, and that's what the patients, the rest of their time, right, there's gonna be on-site support. But we also need to be providing the additional services of hosting them at the hotel, providing food, all those types of things. So for what it's worth,
Right,
I
I'm
think.
not buying Sudafed in Walgreens, and someone says next guest, that's ridiculous, I'm a customer, okay? And these, and the folks who are coming here, their
when we
needs-
open up Walgreens, look at that.
Yeah,
I get that.
but their needs are
Yes,
based upon clinical needs
absolutely.
and their clients and patients. I'm just saying it's
But I
important.
think it's also, I think it's important to also realize the people don't want to be called clients and patients.
right.
And I think you have to also approach this, in this room, I agree with you. But outside of this room, the reference has to be that it's not demeaning when someone hears client or patient.
But can I say something? And someone mentioned it's gonna be on YouTube forever, so just for that.
I got, yeah, this is that moment where like.
Can I say
Go
something?
ahead, Amar.
And honestly, like not, but just to be, because honestly, this is a public meeting, right?
Yes.
So this is just also in line with OMH. We literally just talked to OMH today. They really do not want us touching the rooms of the patients. They're very protective of that space, and they want to make sure that the rooms are for the clients, for the patients, and the treatment is in a specific. So we're trying to be careful also to appease OMH to make sure that we're not mixing rooms with treatment,
Yeah, but
so that the whole
I'll
thing
be
is.
curious about that when we have our questions at the end, Joe.
Yeah.
About OME.
Yeah.
You said OME,
Oh.
something or other.
I'm happy to explain it, but initially we wanted to be completely transparent. We wanted to be able to go in the room and sit with the patient and give them treatment, but OMH put down, said, nope, the rooms is the way they live. Treatment is separate, so that's why we're trying to like, walk that line between,
I also want to say that
Regulatory institution.
Yeah.
in terms of the distinctions between DHS and HMH, it's important for us to continue to emphasize those, and client is DHS language, right? Whether it's accurate for this or not, different question. But as a part of that language for DHS, that comes with certain sort of rights and inflexibility that are not true of this program. So for instance,
This is a medical program.
it is, and we are selecting who can come into the program, we can select if people leave the program. There is not that DHS obligation here. So that's the other reason why, I think client can be a little bit challenging for us as a term.
I'm writing it down.
Next slide.
yes.
Yes.
please. Yeah.
So patient.
Well, it's an outpatient facility, so,
So this is the staffing that's gonna take care of
Yeah.
our patients. We're trying to prove
Yeah.
it.
the patients
Just
get,
for me, just for them.
the 46 people that will be receiving services here will have the following
Yes.
staff.
But I cannot mention this, so we can go over it maybe briefly, but just to give you the, breadth, and there's nothing like this honestly in New York right now. When you have a place where you have your own place to live, you're getting meals, and you're getting a whole treatment team literally in the building where you're living, including psychiatrists. Again, because we're part of Bellevue, this is available 24/7. We have social workers, we have peers. These are people with lived experience who are able to engage with the patients, connect with them. We have nurses around the clock. So the nurses will also take care of any medical emergencies. And we would take care of this discreetly as H&H. You're not gonna have ambulances coming in every 5 minutes because we are able to transport those people to our own facilities to treat them. We have occupational therapists who are able to help patients with their skills, so they're able to function independently in the community. And psych techs. So psych techs are nursing support staff who are able to de-escalate. So if there's any safety concerns, they're able to intervene. But we also have security. So if that's needed, we can use security as well.
In the building,
Yes,
not outside.
In the building.
in the building.
Could we ask you, just to run through that again, tell us how many,
It's in the survey.
No.
You guys can take a look.
no, per shift?
Yeah, it's in the survey, I believe,
Well, just,
that it's in the Dropbox.
Right, but
Just-
we don't-
oh, You don't know it off the top.
but the
Like,
drop,
we
the
don't
Dropbox,
off the top.
the Dropbox information came today, so I'm trying to get this out.
It's
Just
around
roughly.
10 to 12 on like Monday to Friday, 10 to 12, always at least 4 a month. If you go 2 in the morning on a Tuesday,
So 10 to 12 staff, 24/7.
10 to 12 staff on the peaks, 9 to 5, Monday to
9 to
Friday.
5, okay,
Then on the quietest times, you're always having at least 4 or 5.
4 or 5, so we'll go for 4 to 8 in the morning, 4 to 5. Right, or 5 day in the morning, 4 to 5, and then the same thing for the weekends. Just trying to get a rough idea of the scale, and that's all, we don't want you.
No, I just wanna make
You're
sure
gonna
folks
fix this
know
as
that it's
you
in the
do
survey.
it, too, you realize that.
Yeah, of course.
Okay, next slide.
I think people in computers, so.
Next slide. Next slide.
And this is the criteria for eligibility, so this is, we kind of talked about this already. Ultimately, the goal is for every single person who leaves Bridgestone Home to end up in permanent supportive housing. So we looked at the criteria for permanent supportive housing and we reverse engineered it to Bridgestone, because we don't want to admit someone, spend time with them, and then discover that they cannot make it supportive housing. So adult more than 18. We're starting with men because when we look at our data, the majority of patients that we have right now in our system that can qualify are men. And they have to have SMI, they have to come from H&H. That doesn't mean that this is not open to people who are not at H&H. If you, as I mentioned, we've talked about this during the tour, if you have someone that you're concerned about, we have, we're making commitment that you can email us. We have a complex needs team, actually in my office, that's able to facilitate an involuntary removal. So we can bring them into our CPAP, evaluate them. If they need admission, we stabilize them and then we put them in registered home. So we're able to serve really anyone in Manhattan that way. But we just ask that the person comes from our system to register them, so we can make sure that they're stable and appropriate for this program. They have to be independent in their ADLs. This is not like a nursing facility. This is not a psych unit. This is not gonna be people walking and like stumbling and like this is gonna be people who are able to function in a private room on their own in the community. The treatment is to support them with their treatment. This is not to support them with their activities of daily living. And they have to agree to be there. Next slide.
Yes.
So these are the ultimate goals of the program. I can summarize it again. Permanent housing is the #1 goal, but the outcomes is specifically serving around 46 people at any given time. We want to increase engagement in treatment, and we want to minimize that revolving door, which shows as utilization of psychiatric ER and inpatient units. And that's what.
Okay, so as we said, the mayor announced this program in January. As was noted, the 4 H&H's board voted on the lease in July. Chris, when did we get the keys to the hotel?
Yesterday.
Yesterday, we got the keys to the hotel. And so Chris is working around the clock to make sure we're ready to open. We are planning at this point to open next Thursday. I want to say we are not going to open with 46 people. We're going to open with a small group of folks. We're going to understand how the dynamics are, how it's working, how the staffing is going, and then we will scale as we kind of learn more, understand more, troubleshoot where needed.
And make changes as needed.
Absolutely,
Yeah.
absolutely. And then, we're looking to start a cab. We've talked to a lot of folks about this. If you have recommendations for who should join, if you want to join, let us know. And we will start those meetings up as well.
And CAB is Community Advisory Board for the university. I've heard that before, most of the sheriffs have CABs. And they normally meet a lot initially to work through issues and problems, and then most of the facilities sort of stabilize out, and they meet then just a couple times a year.
Yeah.
And then every now and then a facility will open and be okay, and then we do it constantly, try to resolve it. 330.
I will say, all H&H facilities don't have cabs.
So, I have a number of questions. I know Hector had his hand up and I saw JD,
And Brian.
a number of hands up. I'm gonna go first because I'm coaching. So the expected duration, if I got this correctly, is up to 1 year. That's May or may not be that case, but up to 1 year. And are the folks there mandated to take medication?
No, they're not mandated, but in a way, that year you have to have milestones, you have to meet your milestones, obviously. So if you're not taking your medications and you're decompensating,
Right.
you're not gonna get the program, right? So.
But what
Is
happened?
is there also a plan for when patients are being released from inpatient? Is there an arrangement or a plan that you have that they would get an injectable for 1 month
Yes.
prior to?
100%, that's one of the milestones, is to make sure that almost every single person is evaluated for long-acting injectables. That's the goal of the program. Is to-
Every patient who's admitted there has to be.
That has to be, but we're gonna try our best.
And
We wanna start them on the injection while they're with us in the hospital,
Mhm.
and then just maintain it while they're at digital home. That's the goal.
We should also say folks are gonna sign a good neighbor policy, which is also in the Dropbox. And so if people are not abiding by the good neighbor policy, then we are not obligated to continue working with them. in this
And you're
manner.
not in a landlord-tenant relationship, it's.
Correct.
Yeah.
So there's not
Correct.
that issue with DHS, right?
And the
Exactly.
date expected to open would be next Thursday, and I did not get a chance to visit, so I would like to do
No,
that.
I'm actually.
I know that you were able to.
No, we didn't go in the building.
No, we wanted to walk through. I believe Jesse.
So we would have a.
Yeah.
Please,
I forgot.
Jesse has worked with us for something, so yes, we're good.
Inpatient average stay. is what?
21 days on a regular unit, 120 days for the extended care
Right.
unit.
But I think part of that, Maria, also needs to remember is like people are incentivized to stay longer because their discharge options are not meeting their needs. So maybe if you have a better discharge option, people will leave sooner, which is.
From your inpatient bed.
Right, right,
Yeah,
we didn't think
yeah.
that to the program. And just for clarity, OMH saying that you can't go into the rooms, did you mean by for service or?
Yes, yeah, they don't want us delivering
New York
services.
State OMH.
Yeah, they're worried about,
Yes.
what's that?
No, I'm sorry, Greg.
No, I think you said.
No, I'm just saying, in the bedrooms, they don't want
Yeah.
you guys, they want you guys in the facility with services being provided.
In the building, but the building is gonna, maybe Kristen talk more about this, so the Rich to Home is gonna have 8 spaces that are designated as the treatment spaces.
Okay.
And there's a common area in the hallway, so as long as we're doing it there, it's fine. They don't want us doing it inside the room because they're worried about autonomy and ability of patients to say no, because.
No, I'm fine, I didn't, I was just curious about that, and I was curious about just also in terms of like. Safety and ensuring that there's nothing for cause of concern in the room, how are you ensuring that?
Oh, sorry, yeah.
Yeah, we're gonna be going in, you know, the housekeeping crew will go in a couple times a week to be cleaning, they would certainly be flagging things. We have the master keys that were allowed in there. Omar had mentioned sort of everyone's consenting to be a part of the program. Part of that consent is that if we have a concern for well-being, we can open the door ourselves and go check on them, right? We'd obviously be knocking, we'd be going in with a security guard, all those sorts of protocols that would happen, but we absolutely can go in there if we're
And what's
concerned.
your first name?
Chris,
Chris, staff to patient ratio.
well, we're gonna have up to 46 patients
Right.
and then 1-to-1 maybe, if you count everybody, I mean, I forget how many FTEs we have total, it's probably actually 2-to-1.
2-to-1, FTE stands for,
Full-time.
Full-time
Employees, right?
thank you.
So.
So also, though, I'm gonna say something, Maria, on the, in terms of the room policy, when we did HERCS, it was the same thing, right? And we were running sites that had thousands of people in them. Same thing, you know, we were not kind of forcing ourselves into people's rooms, certainly, they had the ability to kind of allow us in or not as they chose. But we had other ways of understanding if there was an issue, if we needed to escalate, you know, if you heard a noise in the hall, you can knock on the door, you can ask if everything's okay. So we have, you know, kind of those policies.
But just one clarification there, they have the choice of us coming in or not, but at the end of the day, we need to get in.
Yeah.
Absolutely.
Right, I think
There will be.
any sort of.
Yeah.
As you know, I run mental health programs, you will obviously need to go in because stuff happens.
Right.
And you wanna catch that early, so
Yeah.
it does become.
And maybe the
It's
confusion,
the HERCS too.
I know,
Yeah.
but I know, but the concentration is, everyone here has a diagnosis.
Yeah, it's
Just
just
the person was broad, some did, some didn't.
Right.
but just to clarify the confusion, when I use the word services, I was being very technical, I meant treatment services and like giving the medications and everything we're talking about, I didn't consider that services, this is what we do in the
Right,
program.
I understood
What I meant to,
what you were saying.
Yeah.
That's what I thought, understood you to mean. And just the procedure for removing patients that are very problematic or are not following their good neighbor policy, whatever, however you frame it, what is the procedure going to be?
Yeah, so we'll be able to work to, in effect, discharge them, right? And we'd be, you know, what we used in other programs and something along here, at the most fundamental level, we'd be talking with folks if it's a minor violation, right? They're not, you know, they're not cleaning the room over and over and over again, and there's a bug infestation, and they're not being able to take care of themselves at the end of the day, or they're being aggressive towards staff. If things escalate, we will be able to, in effect, put them out. Laura mentioned earlier that we don't have those same sorts of requirements as DHS in this scenario. If they're not right for our program, they're not right for our program. This is a clinical program that also is providing these services. At the end of the day, if they're not right for our program, they're still gonna be eligible for DHS. It's not that the city isn't providing some sort of housing service for them if they need it.
And so does that mean you have an actual policy and procedure, or does that mean you have flexible, you
No,
will
we have
do
a-
what works for each person? I
We
need
have a
that.
policy and procedure, but of course, it's gonna be situational of, in terms of, you know, it's gonna be different if somebody's being very good about maintaining their care plan and they had an outburst in the moment. And we're like, okay, we think this is sort of an exception to the rule here, or if it seems like, okay, this is a pattern and they're not gonna be the right fit for
Compliance
this
have
program.
guests,
Thank you.
Right,
can clients have guests?
there's visitor policy, I think we have 7 days a week, it's 2 hours in the morning and 2 hours in the evening, if I'm remembering correctly. One visitor at a time, all visitors sign in, sign out,
And no overnight stays.
no overnight stays.
And, last question, what is, oh, you said a small number of folks, what does that mean?
In the
When you're
beginning?
opening up,
When we're opening, I think we've said we're starting with about 5.
Up to 5 at the
Up to 5.
beginning. Honestly, it'll probably even be a little slower than that. It'll probably be a very, like, less than 5 late next week, then the following week, a few more. So if we, let's say we did 5 a week per week to get up to that 46, that would take 9 weeks, right? So a little over 2 months at that pace. Honestly, I think it's probably even gonna be a bit slower than that. So I'd say we're gonna take up to 3 months-ish to sort of fill in the building, which will give us time to work through the issues that inevitably will be arising.
Right.
And we'll be able to start continue having the conversations with you all, as we continue to grow.
Thank you, Chris, and those were my questions. I do think that there are some pros and cons here, which I definitely appreciate. I have more pros on my list, but.
So Brian?
Thank you.
I'm actually first wondering what this injection is that they get for the month.
Oh my, go ahead.
Yeah, I mean, it's a medication, but it comes in an injection form. It's the exact same medication that they take by mouth. It's just a formulation.
Okay, so it's a big city. It's really interesting that, you know, you said it has to this. Your location decision was even giving your Bellevue. Well,
We actually didn't finish that slide. There were a few other
yeah,
categories.
what, can you walk through like, what
Sure.
else was in your decision?
So it's a great question. So again, proximity to Bellevue is important. We also needed to find a site that could have about 50 people in it. But we knew we were gonna use a whole building. So, you know, I know there's a lot of hotels around. People will say, oh, look at this great hotel. It's huge. Use that one. We're not gonna go into an entire hotel and only use, 46 units and then some common space. It doesn't make sense for us from the budget perspective, doesn't make sense operationally. So we had to find a site that was also like the exact right size essentially. We looked for places where we could turn space or have space already that could be used for the services. And so all of those elements were a part of the discussion and sort of understanding it. DHS helped us find the location. They recommended it, or they suggested, I wouldn't say recommend, they understood that the hotelier here would be open to allow
On
it.
the DHS list, to be rented for social service use, that's what it is.
I have no idea what's on the list.
Well, no, well, that's, it's. DHS we found out subsequently that DHS maintains a list of people who own hotels. Who want to lease to the city of New York for some social service purpose. And DHS made this specific site recommendation to H&H, that's what you said happened.
We asked DHS for sites in this relative area of Bellevue at this size, and this is one of the sites they provided to us, and this is the only one that worked for sort of the criteria we needed.
And is everyone else in there, like, it's gonna be, you're gonna take this over, it's gonna be totally empty?
Correct, well, until we have people there, yeah,
Yep.
but it won't
we
have
already took it
full
over.
guests.
We already took it over and there's no sort of public guests. It's entirely for our.
They've never leased the entire building, Brian.
Any other questions? All right.
Charles.
I have a couple, so do you want them all at once or you want them slowly? So the first question is I'm really glad to hear about the care management service coordination. Are you connecting them to Medicaid, Social Security, those things? Are you connecting them to family? Or are you connecting them to nonprofits?
Yeah, so I would say this. It is already, a lot of that is already sort of built into the H&H system, right? Our patients predominantly come in on Medicaid, Medicare. And if they aren't, they will be enrolled to the extent that they can in these programs. So that's sort of happening already as a part of the general flow of things. In terms of case management, we also have case management social workers in the hospital. In terms of the sort of providers on site, that is all within H&H. I don't know, Jason and Omar, if you want to expand more on sort of the other workflows that may be in the space. And then also, we've been meeting, Dina and I in particular, with some other folks as well, with the local service providers to talk about what everyone else is doing, experiencing, and sort of how we can all work together and, overlap where it makes sense and work together.
I'll give one example of a nonprofit that we're absolutely working with Fountain House, so they have a clubhouse nearby. We're already talking to them about what it looks like to connect our patients, guests, clients to that.
Is it the clubhouse on 37th Street?
I believe so, yeah.
No, it's
Or
The main clubhouse
in
is on 47th Street,
There is another.
but on 37th Street, they have a small 12-bed shelter in that building.
Not
Yeah.
that, the one that's further.
47th Street.
And maybe this is the underlying thing that this is a program, it's not just like a shelter where people just hang out. This is a program structure, there are milestones you have to meet them, you go to supportive housing, you have to be able to follow the whole thing. Yeah, you're not there, you know?
So the next question is, can you talk a little bit about staff training, particularly cultural sensitivity within it?
Yeah, and I think we put in the full list in the what was the?
Survey.
In the document, but there's a lot more detail in there.
A
And
little Spanish, that came today, so.
yeah.
We got it Friday.
It's hard to get it in before the meeting. You all can speak best to the trust training. I'd say that's a big piece of the core element of it.
Oh, yeah, so yeah, definitely, so we, and again, this is the nice thing about this being part of the H&H, that we have. Let me just say everything, but we have a lot going on in our system. One of it is the trust training, which is OMH certified training for all our behavioral staff. They get it once a year, and it helps train people on how to work with clients, patients, guests, to de-escalate violent situations, to build rapport, how to talk to patients, and so it's focused on safety, but it's also focused on trauma-informed establishment for the patients. And also, yeah, and when it comes to H&H, I don't have the numbers off the top of my head, but for us, we talk about the patient we take care of. This is in the fabric, in the everything we do, especially since it's in our mission.
Yeah, I wanted to hear it, like I wanted to hear it from you.
Yeah.
I guess my last two questions is, as you think about advocacy in order to build wraparound services, what have you built into your process to advocate for the continuum of care? And then the last comment is, I would love to be a part of the CAB.
Oh, yeah.
Have you, thank you. Sorry, when you say advocate, who do you mean to?
Meaning to whoever makes decisions that you need to
Understood.
ensure, and that could also be, in my head, in my experience, in partnership with nonprofits or other groups, etc.
Yeah, I mean, for us, honestly, this program in and of itself is a result of it, right? And so we literally have been asking for this for years. And the only reason we have it is because we asked for it, and we made the case for it, and we asked the city, and the city was very supportive to give it to our patients that they really needed. But more than advocacy, we've been doing stuff. So for example, here at H&H, in the last few years, we've been very laser focused on increasing services for patients with severe mental illness, and specifically people with complex needs. Those are people that have multiple needs. So we opened those 3 extended care units that I mentioned. We didn't have them years ago. Now we have them. We restored our inpatient beds. We opened the safety net clinics. We have the show vans. I don't know if you've seen them around.
No, I haven't.
But the show vans is a program that we run. These are vans, street, homeless, outreach, and wellness units. They're stationed in different parts of the city. We hand out, food, items. We do basic medical screening. We do substance use, screening and intervention. So we run those ourselves. I did this all in the last few years. We've built our own crisis critical time intervention team, CTI team. So we have 5 of those now that we didn't have last year. These are teams of 10 healthcare professionals each that work with patients for up to 9 months to have them engaged in the community. So we have, I could keep going on, but like.
Thank you, you answered the questions.
Yeah.
Thank you so much.
But the safety net clinics are important, because those are specifically for folks who are homeless, who need outpatient services. And what we've seen is a tremendous turnaround in the health outcomes for the patients that are using those clinics. And so, I think we've learned a lot from that too.
So, just want to bring it back to the location, right? JD, you're next.
Obviously, what you're doing is tremendously important, and we're all greatly respect. But I have a couple of questions, they're not hostile questions, I just want to try to understand some things and maybe solve some problems. All of us in here live around a lot of social services. I live across from one. Recently, one of their clients went out and stabbed 2 people in the neighborhood. And when we talked to them, we said, what's going on? Is this person coming back? They said they cannot help us. So do you have those same kind of privacy restraints? So if somebody.
It's really not covered by HIPAA to say so-and-so's not coming back.
I'm
I'm saying that response
Yeah.
was an odd one, because you're not disclosing anything if you say John Doe is not coming back.
That's right, nevertheless, they would not tell us, so the deep concern. If one of the patients misbehaves bad or something. Can you disclose that, or are you compelled by privacy restraints, not to say?
We need to talk about that.
Yeah, I don't know.
Yeah, I think we're gonna
Yeah,
talk,
that's a,
we'll talk
that's a
about
very
it
fair
when we come
question.
back,
We
yeah.
understand the point, for sure, yeah,
Absolutely.
yeah, but I don't wanna give you the wrong information, so I don't know right now, yeah.
What is the concern? Second, you talked very much about the program in the building. We live outside the building, we live in the community. How do you deal with, I live across from one, we have problems, we try to solve them with, they're good providers, we get along, we're welcoming, but problems arise. I've not heard you talk about that. Okay, so I think we need to talk about that, how do we solve those problems on the street? Presume they have the right to go out and walk around, right? So if they go off their medication, or don't want to speak the time. How do we deal with it?
Understood.
So we need to talk about that, and when you say the cap, and here you say you're gonna be quarterly, what, every 3 or 4 months? That's not sufficient.
So for a new facility, we would have a cap.
We were having to be more than
Community.
Sorry now. So I think you should review that.
We'll happily.
Before you address the outside of the neighborhood community, I think you were touched upon that for a second, the good neighbor policy.
That is certainly one element of it, and I appreciate you raising that. Yes, that's definitely part of it. I think part of the goal of this program is that it is community-based treatment. The idea is that folks have been stabilized, they are on their way, or hopefully on their way to supportive permanent housing, and they are able to be in a community. Which is why a clinician has referred them in and why the site has accepted them and they have agreed to it, right? That's part of what we're trying to connect there, all those different parts. But to the point about the specifics of resolution, we have an email address, which is in the FAQ, it's in the Dropbox, that as soon as the site is open, that email address is active, it'll be monitored 24/7, we will respond to it. It also helps us because when staff are turning over, they don't have to, they can just look in the email box, see what happened. We're also, again, we're gonna have staff there 24/7 that are H&H. So people will be there, you can speak to us, we want to hear from
Yeah, and
folks if there's an issue.
in most facilities, we had Maria stewarded through a very difficult shelter at Second Street, Beach 9 to 10. And we established a phone number that anyone would call because it just helped us get through that initial portion where things were not quite working properly.
And to tell you, we don't have a phone.
No. I'm saying,
We'll get it.
I'm saying, when you do,
Understood.
it also helped the facility identify the 3 people who were causing like 75% of the problem.
Sure.
Kind of thing.
Yeah.
Which is, that was.
Can I just add something to that?
Knock on the door and talk to somebody.
Yes,
It's great.
Yes.
It's very important. My third concern is this. You say these folks are clinically stable.
Yeah,
Okay, I don't know what that means. I guess you know what that means.
Yeah.
What does that mean?
But that's-
Exactly. And I'm sorry, it's a technical
no, go ahead.
thing, but who determines that somebody is clinically stable? I mean, it's an evaluation with. a list.
yeah, and this is connected to actually what I was going to say. So I think we said it earlier, like, we're not DHS, so we don't have to do this. It's not like these are people who are assigned to us and we have to house them.
No matter what.
It's, yeah, exactly. This is the opposite. We want this to succeed more than you guys want this. Like, we have a shared interest here in this program doing well. We cannot have this not do well for us because then we don't have to have this program, right? So this is just a very important point that it's not like we're stuck with 46 people and we somehow have to like keep them there. We want this to make sense and to work, and that's where we're coming from. But as far as clinically stable, it's connected to that in the sense that, being a little bit more direct, people are gonna have to get with the program if they're there. They have to be able to listen. They have to be able to understand when you tell them, it's 10 a.m., the visiting hours are over. Okay, I understand. Right? This is what clinically stable means. It means that they're clear-headed, they're making sense, they're able to understand. And if they're not, then they're not going to stay. So people.
Yeah, but and I understand, maybe I'm wrong, but this is the first time this is being tried out, that's right?
We've done housing, right? And we've housed, I don't know the exact number, like 1,200 people in housing, and we partner with supportive housing. we've done behavioral health, we've done the safety net clinic, we've worked with homeless people. We're bringing those two things together now in this program and putting them together.
But we want to make sure that.
Exactly. We wanna make sure more than you do. Because we don't want just this one.
But I have one last thing. One last thing. Getting people into stable housing is fantastic. I think I'm gonna need that if I'm on this committee board. What is the percentage of success that takes happen?
Yeah, so we can give you, so for example, our experience, and then we can, so for our experience in behavioral health, we have extended care units where people stay up to 120 days. We work with them to get them into housing. 50% of people who leave these units make it into supportive housing.
And so long do they stay?
Up to 120 days.
50%.
In supportive housing.
In the supportive housing,
Yeah.
I don't have that number, right now, we can go back in.
Well, you understand what I'm getting at.
Yeah,
They do stay though.
They do stay, they absolutely right.
Well, that's
Because we follow it for the extended care unit in particular, we're following up on people for about 2 years, right?
Oh.
To make sure that they remain stable in their permanent housing, so at 50%, that's a significant number.
So
for
you stay at their medical and behavioral health provider after they're placed in supportive housing.
We often do, we don't always, right? Sometimes we're gonna refer them to a community provider if they're like outside of our area. Sometimes we're gonna put them or refer them to our outpatient, but we have care managers that are following up with them for 2 years.
That's very different than the DHS model where.
Yes.
Joe, I just wanna,
Goodbye.
Joe, I just wanna wrap up.
Yeah.
Thank you all. We wish you success. You must realize. In my experience, and there are 8 social services in my 2-block association area, 6-block association. 7. The success is how you communicate with your immediate neighbors.
Mhm.
That makes all the difference.
Yeah.
in the world.
Yeah.
All the difference.
Yeah, I started earlier today going directly to some of them, if anybody, I'm gonna be around tomorrow, all next week and everything. If anybody knows specific neighbors that I should be engaging with directly, I'll be meeting every one of them that I can. But if anybody does wanna come by and help make any connections, I'll be there every day, would appreciate any of those connections.
If you make these folks part of the community,
Mhm.
and you get the community involved, that makes all the difference, so please do that.
And I just like Chris, this is also, we've been spending the summer to it before we had the fees.
Right,
To the
but the
hotel.
community is not just other providers.
Yeah.
So I wanna go to Katie and then, Pete.
My main question, I mean, I think this is great, this is very comprehensive, I like that everything is vertically integrated. My main question is, if H&H as the oldest and largest public hospital system, why do we have DHS and why do we have other social service providers? Because it just seems like their model is, we need to keep people in these beds so the city pays us money. And your model is, we want people to go through this program and we wanna serve as many people as possible and not focus on just keeping those beds filled, so we keep our contract. That, I mean, that's
a statement, not a question.
That's what happens.
I'm very,
You know.
no, the only thing I'll say, and thank you for
Yeah.
says the compliment. What I will say is that DHS has a specific mission.
Yeah.
That is different from the H&H mission, although very much related, right? Our mission is to provide care to people, no matter their insurance status, no matter their immigration status, name your list of criteria. DHS's mandate is to provide shelter placement for oftentimes the same group of people. And so while we are, I think, overlapped in many philosophic goals, there are differences. There are a lot of differences because our mandates are very different.
You are
And then-
definitely going into statesmanship.
Then how, can just add one thing, I mean, there is an obligation of the city to provide everyone
Yeah.
shelter.
Yeah, that's in my point.
That does not.
Well, our
Yeah.
obligation is to provide everyone medical care,
But
so.
like, not necessarily shelter.
Yeah, but it gets a little tricky, and I think, now that we've seen, COVID, and I think that's really when this whole, I want a private room, this helps me the most starts. Because I interacted with a lot of people who went from a congregate shelter and were living in their own home, in their own room. And it was a huge help to them, and as soon as they went back to the congregate shelter, everything went to shit. unfortunately. When it comes to proximity and the list of hotels, were there multiple options that hit your criteria?
No, not all criteria.
Okay, so of all your criteria, was this just like the only one, or were there like one or two and it was?
No, there were other options. Well, option is a strong word. There were other locations that we looked at that were not able to meet the needs of the program for a variety of reasons.
And we did ask them the tour, we disclosed that, we haven't received that information, correct? And I'm
Correct.
assuming you're not gonna disclose that.
It's not our information. I mean,
No. You're not, just say you're not gonna disclose
Right.
that. Sorry.
I just
Kate.
have one last, this is again, just a quick point. Eric Adams, mayor, did a town hall. I'm not sure if any of you were there at, Beacon High School. This was in May. And we did talk about social services and the overconcentration of social services, specifically in Hell's Kitchen, the West 30s, West 40s area. And in response to that, the mayor said, we should not pack everything in Hell's Kitchen. The name is Hell's Kitchen. We should not create a hell here. So it should be shared across the entire city. And I want to note that, you know, this is the first time you guys have come to us with this. When you did the HERC, that was great. And the unfortunate situation of why you're going to receive a lot of these questions and pushback is because DHS has really screwed us. They've opened shelter after shelter, moved people into areas where there's active crack dealers on the block, moving women with severe mental illness to these areas. And when those people are outside of their facility, they do not do anything. Most of the people you see on the street who are in a bad way, who are actively using drugs, many of them belong to these facilities.
They're domiciled in a shelter.
And it's just, that's what we're dealing with. And that's why you're hearing a lot of these questions. And I don't want you to take it like we don't trust you, but DHS has really made us not want to trust anybody. Because, you know, what we're supposed to be temporary migrant shelters in hotels in a residential community are now permanent mixed population DHS shelters. And those hotels were used for tourists to go to our businesses and do all these things. And so it's ruining our community. So I just wanted to put that out there so it is understood why this is a very frustrating process and why the lack of early communication is really hard for us.
And I'll just do a code FYI, this is important. Since we met with you, Mount Sinai informed the board it's opening up a new outpatient facility for homeless and troubled teens, substance and alcohol addicted on West 38th Street between 8th and 9th Avenues.
For homeless, next to Ali Forden?
It is one of these moments where we can't believe that we have a conversation and we're trying to get through something, and we have another notification of another facility in the West 30s. Like, why would you do this at a location where there's incredible drug activity in a corridor? Pete was next, and then Kevin.
Yeah, okay, she mentioned just about everything. I have the living room and
You must speak louder, Pete, otherwise can hear you.
I live in a place, and as our we do house individuals who are clients of a nonprofit.
Urban Pathways.
Urban Pathway. You get to know the individuals, and they're pretty much for themselves, but they still have problems. A number of them have no resources, no money. Some have no ability to play their mobile devices, the plans. Some of them you will find outside begging. You won't see them begging in the immediate area, but you see them begging elsewhere. They still have those problems, and it's hard to service them or help them in any way, other than to be a very, very good neighbor, and which we are in our building. We've had problems in the past, and it's not to say we're not gonna have problems in the future, but they're there. Some of them like our building. They don't wanna leave. They prefer living in the city because it's alive. We're very neighborly. We greet each other and we speak to them.
And they share bathrooms?
And we share bathrooms and toilets. My concerns is that, we do have a great number of homeless people in the community. They come from different facilities, but I can just see that much more. I frequent the streets late at night until about 1 or 2 o'clock in the morning, and I see a number of I can steer them to facilities where they can get food, a shower, a place to rest, and get services, but, they still want money. And you can't stop the vending. They just want the money.
So will there be any like job training, access or assistance in like getting these resources?
Oh, all right, well, we can answer 3 questions at once, then you go talk about the occupational therapist.
So that, and they're looking for employment. I've had the last individual, the last thing I heard from him before he died was he was looking for a job. He was so happy to get it.
Wait a minute, sorry, what was the answer though? Did you?
Oh, well, we were gonna let
I'm
Pete
gonna
finish.
answer.
We're gonna let Pete finish.
So, they're looking for jobs as well.
Yeah.
And an opportunity to
I
go
think
forward.
it's a good time to answer the question.
I will
Yeah.
ask it.
Yes.
Yes, so we are actually literally in the middle of rolling this out for our ACT teams. We run almost 8 ACT teams in our system, and we're going to be adding.
Do you know what an ACT team is? Pete?
And can you please?
Oh, sorry, assertive community treatment. Assertive community treatment for teams. They work with patients that carry 6 to 8 patients each, and they provide very intensive care, level of service. So we're adding specific people to those teams to help with employment specifically. So we're gonna be able to leverage that for people with a bit rich to home to help them with employment as well. And we have the occupational therapist on staff, as we mentioned earlier. And that's literally what they do. They help with the skills, with being able to do stuff independently, and they can help with work as well. They can help you together a CV, send it, apply for jobs, stuff like that.
But you'll find that the community, the people who live in this community are your best resources to
Yeah.
help them.
Oh, definitely.
Because they're the ones that give them the encouragement, the hope, or I should say, the sense that there are people that do care.
Yeah.
It's coming from our community.
Yeah.
Kevin and.
So
Richard,
the other thing is, is there a curfew for these individuals who are in the facilities? And in the 446?
There's not a curfew.
No curfew.
There's not a curfew.
And what do the rooms look like in terms of they have TV, Wi-Fi, so they.
TV, Wi-Fi, it's a single bed per room,
If you go online and you've looked at the hotel, the picture you see is
No,
more or less
I
what
assume
you're
it's a
gonna
hotel,
get.
but sometimes-
Well, no, but you can see a picture of the rooms online.
Because,
Okay.
yeah,
that's
that's what they lack, they don't like, they don't have the Wi-Fi, because
There'll be Wi-Fi.
their mobile plans do not,
Right.
support
Right.
enough
Yeah, they
to
don't.
see this on TV, and they would like to
Yeah,
have some.
and this was something, I mean, we learned over and over again in perks, because people were coming from all different countries into the city. They were coming to the Roosevelt Hotel, which Health and Hospitals ran. They had phones, but they didn't have SIM cards that worked here, and so Wi-Fi was like a day one thing we needed to do in every site that we were.
And they only get 5 gigs, so that's not enough to
Yeah.
watch TV, make phone calls, and then.
Yeah.
So I know we had Katie hand up, Kevin, Rachel, Roberta, Hector. Travis had his hand up. Kevin?
Yeah, what's next? Rachel and.
Then the public.
Oh, sorry.
Thank you for your presentation, much appreciated. I have 3 questions, much of which you may have touched upon, but if you could flush it out, that'd be great. Well, no particular order. First, where do the patients come from? In other words, like at CHS and Rikers, we know that there's a significant mental health illness, especially with significant, and then even some folks who just overall diagnosed with mental health illness. Are they coming from CHS, CPEP, psych ERs, inpatient, outpatient,
They're coming from our inpatient units.
at the acutes and?
Yeah, and the acutes.
Right.
So this is what we were talking about, the extended care unit, for instance, is a place patients may be referred from.
A little louder.
So like not from a CPEP, but from an inpatient.
No, they're not gonna come directly from the CPEP into bridge to home. The idea is that they've gone through stabilization, and that's not gonna complete in the CPEP.
Fair enough, thank you. Then, the next 2 questions is break it down into benefits, elevation, benefits to the community.
Mhm.
Right, if you're looking down the road, 12, 24, 36 months down the road. How would you define success? What metrics are you holding yourself up to? Does it manifest itself, in other words, putting the patient at the center? Is it less acute cases, less ER visits, better medication management? If you're discharging someone to the home, is that success? I think you said you monitor them once they get discharged to the permanent home, 24 months. In other words, what metrics are there that define success for the patient?
Yeah, I mean, the ultimate metric is housing. So we want to make sure that people are placed in supportive housing. So that's the ultimate goal. And then the secondary kind of metrics are exactly what you just said, which is decreased utilization. So, you know, we don't want them ending up back in the CPAP or in psych units and just kind of like staying in the community.
Gotcha. And the last question is potential benefits to the community.
Yeah.
Is it, would you purport that front and center these days is a concern about access to behavioral health issues, people who are homeless with mental health issues or emotionally disturbed people, that if this is successful and you scale it up elsewhere, that the potential could be less homeless, less EDPs on the street, and then that's what success could look like as a potential benefits that communities will.
Yeah, I mean, 100%. We talked about this on the tour and we would repeat it again. We are more than happy to partner with the specific community around Richmond Home. So we're not bringing in net new people into the area. If you have people, which we saw, and I know for a fact that you do have now, because we did the walkthrough, we
So
saw
the whole Midtown initiative, yeah.
right? We saw a couple of
On our tour, we actually were confronted by a very aggressive person.
Yeah.
And everyone sort of carefully took photos, whatever, because this person was severely mentally ill, but very aggressive in the Labs Park.
right. And our thinking
It was a
and
light day.
Who?
It was a.
Oh, it was a very light day.
Yeah,
I'm talking about the one guy who was really.
yeah, but we, you know, I live in Chelsea, down the street from me, so I think we all, you know what we're talking about. So ultimately, our thinking is that these people are already in the area, but they're on the street, in the park, on the sidewalk. So now that we have a program like this, and the goal is to have more than one, then we can have them living in their own private room.
And the other ones wouldn't be in this neighborhood.
Yeah, they would be the same.
Just to make it.
Yeah.
Yeah.
Nowhere close to here, but the idea also is that we have a mechanism right now through our complex needs team, which is a team that focuses on people with complex needs. So if you have someone that you're concerned about, you can email us. And then we can activate an involuntary removal because we work with DHS and the outreach teams already very closely. We can say that there's this person, would be interested in having them come to Richmond Home. They can come to us, we treat them, we stabilize them, and then we can refer them to Richmond Home. So that would be an ultimate success all around, because not only we would be placing people in supportive housing, but we would be reducing homelessness in the area where these programs are.
That's a great question. I'll say that one more time because it's fascinating. So you are saying that you would get referrals of folks who need help.
And ultimately, if it's scaled up, you have to.
Correct, but again, if
we would
get a referral,
Indeed.
someone could do they can do an involuntary, like that individual we all saw that day clearly was desperate.
And if you notice, it happened because the person from DHS took the picture.
Yeah.
And they did act like literally as we were walking. If we were, I'm sorry to say it that way, but if we were not there that day, it probably would not have happened.
Well,
right?
As Brian noted,
Yeah.
there was a sweep by DHS in the morning of our tour. And I would say 40 to 50 people got removed from various locations, and we all noted it because our assembly member lives in the district, in the area. So it's this moment, but that was an extreme case.
But even the sweep, you could see that as an example of how we all working together could be doing something like that.
No, the sweep is about making a nice, background of the tour.
Yeah.
We go to Rachel.
Thank you. First of all, genuinely appreciate you engaging us in this dialogue and for the comprehensive services we provide to address one of the most critical needs the city has. I think I have 2 questions, or maybe 3, depending how it goes. So for the 12-month period, what happens if a resident has not secured permanent housing by the end of that period?
Yeah, so look, we're not trying to make punitive here. Somebody is making their way through the supportive
I'm not
housing
gonna
process.
discharge them.
No, and they need a few more weeks. The idea is to make sure that people have that kind of warm handoff to supportive housing. So if you need a little extra time, we are not gonna be,
So let me do a follow-up, which is very germane to that. I have personally experienced this in my work. People turn down supportive housing.
That's the thing.
And I will tell you that this is very disturbing. Someone says, no, I don't want, let alone a shared apartment, I don't want a studio. I want a one bedroom, I want a city theft voucher, I will stay at Bridge to Home. I've been like unbelievably like, how do we get into this spot where people are saying they prefer to stay with they are? What would you do in a case like that?
I think we have a rule 3, they have the choice, they have the right to refuse 3 placements.
That's what DHS's entire policy used to be. Used to be they go 3 referrals, and if they turn them down, they go to the bottom of the list and they wait in. So that's a very interesting, and it says it in your actual protocols.
Yeah, in our case, right? Yeah.
And then you can just,
they're out.
you just.
No, they don't go back to them, they're out, because they need to give room to someone else.
No, that's we talk about this a lot, and that's a very like thoughtful thing. It helps give people an incentive to try to get placed.
Oh, yeah.
Yeah, sorry, so.
Again, it's a program, this is not based just hang out, this is a program that you have to complete.
It's good to know that there are, I guess, systems or, rules in place to help achieve that, but to use Charles's term from earlier, what kind of advocacy or dialogue, or, as Pete mentioned, that kind of support the conversation are you having with the patients to help encourage them to move towards permanent housing then? That wasn't my second question, that was a follow-up.
Well, so honestly, they wouldn't be at Bridge to Home.
Yeah.
Because again, we have a huge system, we have 1,100 beds in our system, so we're having patients all around, all the time. So if you are not interested in going to supportive housing, you're not gonna come to Bridge.
But what if they change their mind towards the end?
Yeah.
It's like, cause it is a long.
Oh, right.
Yeah, TV, it's.
Oh, yeah.
Safe,
Yeah, that's the whole team that you saw there, so you have peers, you have social workers,
Okay,
you have occupational therapists, you have the.
and that is for the ongoing.
Of course, and the ratio that Chris talked about, I don't know if you heard what he said, it's 1-to-1. So you did, so just to give you an idea, an acting.
At a maximum,
Like,
but it's
But just to.
volumes between one to one.
You have, right now, the highest level of care is an ACT team. If you ask anyone, what's the highest level of care is an ACT team? ACT team, you have 1 psychiatrist for 68 patients.
6'8"?
68 is correct, 68,
Yeah.
right? Here, you're having 1 psychiatrist for 46 people. Right, you're having a social, so this is a very, very intensive level of staff.
That's all, no,
Yeah.
and in terms of the eligibility criteria, so there was a list of, things including, identify as male, 80 years or older. So, and I think you mentioned during the presentation that was reverse engineered based on those already in the H&H network, so it was kind of an idea to how do we best serve the majority
Like
of
the
our.
demographic.
Just for the
Right.
men, just for the men.
Just for the, okay, so I guess my question is, what happens to a female, non-gender conforming, or, a youth, member, if they're already in the H network, and what happens to them? And they do want to have.
I mean, our goal is ultimately to be able to expand the program so that anybody who can be referred in, who wants to be a part of it, who the site agrees to, can enter the site. This is we see this as the beginning. This is the population that we have the most represented in the behavioral health world at this point, in the extended care units, et cetera. So we're trying to, let's start by serving the population that is most
I see, okay, maybe that's tied to kind of, you have to start with a certain number of,
exactly,
units, and then that's the,
Yeah.
that's helpful to understand. It wasn't clear if it was like, okay, if you don't meet these, then too bad, even if you're first on the list,
For right
You don't
now,
have that.
for right now, those are the criteria that we're following, but as the program goes on, we would look to be much more.
That's perfect, and that segues perfectly into my last point, not a question, which is, it was great to hear that you are making this as affordable and accessible, regardless of financial or immigration background, so that is kind of the critical concern that we have as a city, so hopefully that continues to be your priority and model for your operations.
Yeah, absolutely, and I think like when you work in H&H, like you learn all of the reasons people don't go to seek healthcare. They're afraid of what it's gonna cost, they're afraid they're gonna get asked about their immigration status, they're gonna be asked about insurance. They're, gonna be asked a bunch of other questions that they don't want to discuss. And so we really have thought, not just in Bridge to Home, but also in the H&H spectrum of care anyway. How can we close as many of those barriers, create that confidence with patients?
Thank you so much.
Thank you. We're gonna go to Katie, followed by Lee.
Hi. Thank you for this presentation and, I have just a couple questions. So we all know that there are nearly enough, permanent supportive housing beds to meet demand in the city. It's,
Absolutely.
and so I guess this maybe follows on a little bit to Rachel's question, but, as you said earlier, there are not very many good discharge options, which is why people are staying in the extended care units, right? So I guess I'm wondering, and I'm on the board of ERC and I know that, we do have programs, obviously, we're trying to help people find permanent support housing. And they have the psychiatric care and everything else, and there just aren't places for them to go. And I know you mentioned, they need help extra weeks. My understanding from what little I've heard is that it's not a couple extra weeks, like it takes well more than 12 months. So I guess I'm wondering, because you're basing on 12 months right now, are you finding with your experience that somehow there is some cadre of permanently supported beds that are available to you that might not be available to others? Or I'm wondering, like, where is your 12-month estimate?
No, it is coming from our experience at housing hospitals and with our Housing for Health team. I think part of why it can take upwards over 12 months is like you can start and restart the process multiple times.
Oh, yeah.
Right? So with it being one part of the continuum, we're one process, right? Instead of having to do another 2010E, another mental health report, another evaluation, we have it all baked in. And it's all gonna be part of those milestones that Omar was talking about, right? So we believe we can streamline it because it's all part of the H&H.
You're managing it from soup to nuts.
Exactly.
Through the referral
Correct.
process.
And
I
it
don't
seems
know,
like you're saying that you wouldn't, like, if somebody hasn't rejected 3, if they haven't even got the 1, and they've been there 14 or 15 months, you're not gonna toss them out.
No, and quite frankly, we're gonna be talking to our Housing for Health team, we're gonna be looking at the individual, the profile of the individual. And figuring out why, probably at the 6-month mark, right? We're not gonna be waiting to 12, 15 or so months. If at 6 months, A, if they're not clinically stable, but B, if they haven't had a housing interview or had identified housing, we're gonna be talking to our Housing for Health team to be like, what's going on? Right? Why is this person not being matched? And maybe it's what, their profile, maybe it's, what they're looking for, maybe it's, X, Y, or Z, and we're gonna try to solve those at the 6 month.
And you are making referrals directly to the supportive housing, not through GHS system?
We'd be going through HRA,
HRA, through
Yeah.
HRA system.
absolutely, not through the.
They do all
DHS
the
system.
referrals for supportive
Yeah.
housing, even for our own supportive
Yeah,
housing.
you just notice that system is not the highest functioning. of the
Yeah.
program.
Even though, Joe, even for the supportive housing units that are on H&H sites, we don't refer our own patients into
Right.
those buildings, we refer them to HRA,
Yeah.
understanding they are from our patient pool, and
Yeah.
then they can be referred into our.
That can be tricky, and that is.
That's one of our.
Yeah, the
Sure,
process is
sure.
not smooth. I have 2 more quick questions.
Understood.
So one, I know, we all know, when people are struggling with severe mental illness, even if they're stable, they may have a time when they are not so stable, or they're having an issue. And we know that they walk away from things. And we know that sometimes you just have to support them, right? And so I guess my question is what is your protocol? If somebody has been with you for 6 months and they've really been working hard, and then they just say, screw you all, they walk away, and then a week later or 2 days later, they come back, are they allowed back in the program?
Yeah, so this would be one of those moments where it's sort of situational, right? Like.
You have a protocol, but you manage it.
The policy is if somebody disappears for 5 days, they lose their space. Like, if they're going to visit family out of town and they say, hey, I'll be back in a week, that's still their spot when they get back. We don't want them to lose that progress, we want them to build those family connections or maintain them. But if they disappear for 5 days, by policy, they lose the bed. Now, if they came back at day 7 and
There was a bed.
they have the explanation, they, and there is space, like, right, we wouldn't want. I looked at the clinicians, right, but I don't think we'd wanna lose that progress that had been maintained, that they did go visit family or whatever it was that they were doing, but they're still stable, they're still committed to their care plan, they're still committed to working through the housing application.
Well,
All of those
improvement
sorts
is not straight line, improvement is.
Yeah.
Right, if we have that sort of setback, we'd wanna make those exceptions, but by policy, it would be 5 days. They'd
Okay.
And I think
And the nice
also,
thing,
go ahead.
just the nice thing with our system is that we could potentially amend them, hold them until there's a better amendment, right? So that's the nice thing about the continuum that we have.
If they're regressing.
Yep.
And my last question, you mentioned that you think that the ramp up is gonna be pretty slow in the building. I guess it surprises me, because we all know how much demand is out there. and-
We can make it faster if you want.
No, we would like it to work, actually.
But why? Yeah, so why are you doing it in that way? Is it because you don't think there'll be much demand, or because you think that there aren't many people who have been diagnosed as sort of clinically stable who are ready for this, or sort of where is?
Yeah, so
Why then?
there's a few pieces and others, please jump in, but there's a few elements to it, right? One piece is sort of those referrals coming in, right? Who's actually sort of, what did we say, 21 days for inpatient, right? Sort of who's at their 21-day discharge point that fits the criteria that we laid out, that also wants to consent to come into the program. So there's all of those pieces. Then there's sort of the operational element as a non-clinician that I'd say, okay, this is a new program. It's sort of a new particular model. We want to make sure that we are doing the intake the right way. We want to make sure that we're orienting guests, patients, clients to the building and the neighborhood the right way, that we're working through those issues with the neighbors the way that we want to be working through. And that's going to be a whole lot easier. In this circumstance, we kind of have the, maybe not the right word, but we sort of have the luxury. We have the flexibility to take it a little slow. And so we prefer to do that so that we can have a little more time to learn as we go, including from you all, about how we can be the best neighbors we can be.
I think there's another element of this, which is I get to use a fancy French word, the milieu of the building, right? Like how everyone interacts together. I think if you throw, 46 folks in all at the same
Super chaotic
time,
at once.
very, very chaotic, right? And that's not what we're trying to do, right? We do want to, it's a new program, new folks, we wanna do it slowly so that people actually, jive together, if you will.
You may invite somebody and they don't fit because they think the world is their oyster all of a sudden.
Whatever, yeah.
For whatever reason, and you have to say that person's gotta be.
Or we need to spend more time with that individual, right? So to look at it a different way, right? Maybe we bring someone in that doesn't, fit the milieu, the culture of the place. And we're gonna need to invest more time, more energy, more staff hours into that person so that they do fit, right? So that they are, I think, stable in that environment. And then we let the next person in, and the next person, and the next person, right? So I think that's how
Well, God
we're.
bless her, if you diagnosed a little bit sooner sometimes.
I think, although the other thing, and we learned this all the time in HERPS, was that there were times we had to make operational changes and, we would learn that as the site is open. Oh, we have to shift where the food is, or, where this service is delivered. And so to do that when the site is full is a little more challenging, although we certainly did it at HERPS many times.
Is it okay if I pause you just because I wanna move on to somebody
Like I
else?
said, that was my last question.
Liam,
And we have Hector as well.
and then Brian.
Yeah, I'm interested in kind of like when folks are moving through the community, and to what extent, if at all, are entrances and exits trapped? Like when might you know that somebody didn't come back overnight or something? How would that be flagged?
Yeah, that is a great question. So some folks are familiar with the HERC program. The Watson Hotel is in the district. We had badges along the lines of these, QR code, name, the location. This was an early one, so it didn't have my photo on it. But like, we're gonna have badges like that. They're not gonna be wearing them out in the community, right? Presumably. But when they come back, they'll use this to sort of scan the QR code to sort of swipe in.
Just like you did downstairs, or I.
Right, exactly, yeah, exactly.
Yeah, and so if we see in the system, Chris Keeley hasn't been back in a certain amount of time, we're gonna go do that wellness check. And if we
Really
go into the room, we'll be able to go into the room, all those sorts of things. Also, if they disappeared for those number of days, right, we're gonna be trying to reach out and see where they're at. We're gonna try to find them. We're gonna try to sort of backtrack, same thing, wellness check, even if it's out in the community, not just wellness check if they're on site. We wanna make sure they're doing okay.
Do H&H staff or folks, would you literally walk up and down 10th Avenue and looking for somebody in that situation? I mean, is that?
in a situation where somebody has disappeared, you know, they disappeared, sort of went off the radar here for a day or two, and we happen to know where they spend their time, yeah, like we might have some staff go out and try to spot check of like, hey, did we see them at one of their familiar haunts, just to do that wellness check.
Or if folks email us or
Yeah.
not stop by and say, hey, we think that somebody who is living here is on the street, yeah, I mean, this happened constantly.
And then does, with these counts kind of online, would these count as stipends towards
No.
the total? No, okay.
No,
Certainly not. A bed has to be set by a certain kind of.
Right, this is
kind of license.
Yeah, yeah.
That's the mark I agree with. Stephanie.
It's not an indication, but it's not.
It is
It's
on paper, it is an outpatient satellite clinic of
Yeah,
health.
outpatient.
Yeah.
Alright, thank you.
Go to Hector online and then Roberta. Hector, unmute, so you can hear you. Hector, we cannot hear you.
Text me your question and I can ask.
Yeah,
Okay.
text us from Maria, Roberta.
So I guess firstly, thank you, just to echo what everyone has said about the program, it is really, like admirable, we appreciate, you know, the innovation here. I'm just thinking specifically about the street level activity. One of the questions I had was, is there an outdoor space for people to congregate, in the hotel? And, I think like that just comes out of having, a number of social services in which people will, you know, hang out outside of the building, which totally understandable, but then with certain neighborhood conflicts, and that's what it is.
Yeah, for those that have been by, there is, right, there is some space that we might try to be able to convert, but it's not, honestly, it's not good space for it. We are gonna try to make it work, but I don't think we should expect that there's gonna be an outdoor space to use.
Okay, that's helpful. And then I think we asked a question about discharge. And just the mechanics of discharge, if someone is discharged from the program, they do not go to a different residential facility. Are they just like, you're on 36th Street now, have a good time?
Yeah, that's a great question. So others chime in if you have thoughts on this. I think what we're gonna be looking at there is if somebody is being discharged, we would wanna be sort of providing all the information about DHS intake, you know, get them over to the intake site over near Bellevue. We wanna be able to get them placed there because we don't want them out on the street in that scenario. Now, if we're putting somebody out, there's gonna be a scenario where, you know, if it's for clinical reasons, that might look one way. If it's for a violent incident against a staff member, that discharge might look a little different, and it might not be such a conversation where they're ready to take our referral piece of paper in that moment, right?
So police, there's a violent activity.
Exactly,
Police
right,
activity.
it could be police.
That's a different story.
Right, like we can't hide that those are types of things might happen as well, right? And we're gonna need to work through those things together. So I think it's gonna be situational, but what we would wanna be able to do is provide the DHS information and make that handoff.
And make sure that they're set up with clinical services for treatment in the community, right? So, you know, whether that's another outpatient treatment, but you know, someone is being discharged from the program for. Certainly for something clinical, but even for, you know, something housing related, they might need a higher level of care in the community. So they might need an ACT team, they might need a intensive mobile treatment team. They might need something else that they're not doing, so.
I mean, just to connect it to what I think Katie brought up was just there is concern about you know, just like letting people, abandoning people in a community in an area where you do have, like a relatively high level of, both street homelessness, but also, I mean, you can take drug activity or other, quality of life issues that may be harmful both for the community, but also for the clients, guests, patients.
Yeah.
You'd like to-
Yeah, and I think statistically what we can tell you is that we will likely see this person in our system again anyway, right? It's maybe not going to be in Bridge to Home, but in the CPAC, you know, in any number of ways, we're probably already interacting with them.
And I might just say, and Omar, you can jump in here too, obviously, but like discharge for us is like, it's a thing, right? This is something that we do in all of our settings, all of the time, right? And it is a process, and while we might have to do that process quickly, depending on the issue, you know, it is a process that we are very good at and we do in all of our clinical settings. So, and it's something that we take very seriously.
And it's a hospital that's doing the discharge,
Right.
it's not. So, I hate to say it, it's not DHS, just. we're gonna-
Right. Yep, that makes sense. And then I guess, two more questions, one just clarification. Did you say there were 56 rooms and then 46 are for clients? So
Correct.
10 are like staff and other rooms?
That's for like treatment, for services,
Okay.
for the actual outpatient.
The hotel, there's more hotel rooms. than
Yes.
46.
And then those are like retrofitted for other purposes that are not residential.
Correct.
Okay, that makes sense. And then I guess the last question is just, how can the community, like, people present, someone is listening to this recording, like, how can we be supportive in ensuring the success of this?
Yeah, it's a great question. We appreciate it. I think join the CAB. We'll be meeting more than quarterly for those that are listening back. And I think we can continue to talk about ways to support as we're expanding.
We're gonna go to questions from Hector, which Maria has on her phone, and then we'll go to Brian. And come back to Brian.
Interestingly enough, I have 3 cons, the number of beds, location, and beds aren't mandated, and like Hector, I'm not gonna read everything you wrote, Hector, but he brings up 2 things, and one is, like, how can health and hospitals ensure that locating the bridge to home site doesn't further oversaturate our district compared to other community boards? And I would answer that, Hector, that they cannot ensure that, and in fact, it is oversaturating the area. And his other question was, it was his understanding that there were gonna be 100 beds at this location.
Okay, so I think I know where that's coming from. Do you want me
My
to?
understanding, when I had the meeting with you in July, it was 46, so I'm just curious.
So when this was announced, it was announced as a program that will eventually expand to 2 sites, each having roughly 50 beds. So I think that's where the 100 is coming from, is that in the grand total, by the time
In your overall program, not this.
when we open the second site, it will be roughly 100 beds, but it's never gonna be 100 beds at this site.
Okay.
Just a
And,
Unless we started putting.
and then
Not
he
particularly.
also noted that, he's just concerned that if it becomes out of control, the location, and having this located there, and the impact to the community. That was it. That's not something you can really respond to. I think, having the CAB and taking the steps necessary and being open to the feedback by the CAB, and also like tracking. We'll talk about it at the CAB, so.
So we're going to Brian from the Block Association and Brian's one.
So, I am Brian, where I've met mostly Chris, we met at Tom Harris.
Exactly, that's right.
All right, so, I'm gonna dispense with the niceties and the love fest that you've been having here. I'm gonna talk about the reality on the sidewalk and in our gutter, because 36th Street is a challenge block. I think, and first I just want to comment on this, because it's been a lot of talk this evening, then I do have a specific question. When I was informed of this, it said, why delete here? I was told there was a specific criteria, which you said, proximity to Bellevue. We are not proximal to Bellevue. I can tell you it takes about 30 to 45 minutes to get across town. The size of it, which yes, it is under 56 rooms. And in the DHS pipeline, which we just learned about as a community, there's a lack of transparency there. The 4th criteria, which was not included, which I think is the most critical and important factor, is existing conditions on the street and on the ground in the immediate area. And I know Rhea and Joe are well versed in what's on those immediate blocks, but within a single block radius, you make 8 social service facilities. So there were 7 pre-existing facilities there. On the half block, because it's a half block that is bisected by Dyer Avenue between 9th and 10th Avenue, on your half block, you are now the 3rd social service facility. You're next to an LGBTQ crisis shelter, and we're learning a DHS family shelter. You go about a block down to your east, you have a 100-bed HACA transitional housing facility. You have one of the largest methadone clinics in Midtown, 600+ patients daily on West 35th Street, which is a huge problem in this neighborhood, governed by Oasis, a for-profit entity. And on 37th Street, you have Positive Health, an oxymoron, Housing Works, that is a syringe distribution facility. There are none of these places live in a vacuum. And what we find in our neighborhood is that the transient population is not necessarily all homeless. A lot of them are placed, but they do come to this immediate area for services, whether it be at the methadone clinic or at Housing Works or State Parole Board on 40th Street. And it is a constant collision and layering of all these different activities. Your patients have to walk through this daily. It is a grinder out there. Every day, I see people with severe mental illness, which I guess you would say decompensating on our sidewalks, that are in some state of erratic behavior. I've had to call in on numerous occasions on the committee, and in the immediate surrounding area where your facility is being located. I don't even bother to call the drug activity every day because I see people shoot up every day. It's what happens on West 36th Street. I could take you within a block of your facility and you can buy fentanyl, heroin, or crack very easily. And this is not due to the lack of efforts by the PD, the DA's office, and the Special Narcotics Prosecutor. 8th Avenue corridor was the impetus for the founding of the Midtown Community Improvement Coalition, which is an interagency hub, which I co-chair with Times Square Alliance and Garment District Alliance, specifically tasked with addressing significant quality of life issues, drug use, transient population, panhandling, within the 8th Avenue corridor, approximately from 7th Avenue, 9th Avenue, 35th to, we've expanded it up north into Midtown North as well, up to 57th Street. We have significant issues that your patients will be walking out into daily. And what we have found in dealing with all of these different entities, all these different providers, is none of the patients, or none of the individuals belong to those facilities, or that is what we routinely hear. We routinely hear, how do you know they're ours? Well, I'll tell you how we knew the individual that was living on West 36th Street, directly around the corner from the methadone clinic, for over a year on the street, was a member of their clinic, was because he dropped his ID that was found on the street by a neighbor. And that's how we were connected to DHS, and that's how they were able to temporarily place him. But yes, he was a patient of that facility, living on our street, harassing neighbors, harassing businesses for well over a year. So I think it's really problematic that we have chosen to locate this at this facility. I've spoken to all of our elected officials ad nauseum about it. I asked them to oppose the location. That didn't happen. So now we have this facility here, and I am deeply concerned. My concern is about my neighbors and the surrounding community. But I gotta say, I'm also concerned for the patients reporting into this. Because if I'm someone who's struggling with severe mental illness, I don't really need to be stepping over people using. I also want to point out, DRC does not have a facility in this area, but they do have a office, and they use these streets as their parking lot. DRC, who is involved in the space of helping people on the street, transient, they will literally step over bodies to get into their vehicles. And when I've asked for assistance, they've said, this is not our purview. So that's the reality. There is not a kumbaya cooperation between providers. And there's a reticence for providers to own up and say, yeah, this is our problem. So I'm just sort of dispensing the niceties. I'm really troubled by your side of the program here. The program sounds wonderful in a vacuum, but this neighborhood cannot absorb this facility. Done deal, so I'm screwed there. My question is, we talk about discharge, all right? The reality is that if an individual, and you said that they're here voluntarily, decides they want out, then they're under no obligation to go into DHS's system. They're no longer under obligation to go into any system. But now they're like, I like this neighborhood. I'm gonna stay in Bella Absent Park. I'm gonna stay in the Canoe. What do we do to address that? All right, the other thing is we've had a situation recently, I'm not gonna name the provider, but 255 West 43rd Street. An individual in that was moved out of the program, supported housing. There was an order of protection against that individual, and the only reason that individual was removed from the street is in working with the precinct, I introduced the woman who had the order of protection to the various chains of command within the precinct. So after calling 911, because she couldn't get the facility to do so, she put a call in to the lieutenant and the sergeant involved in Town South, and they picked the guy up within 20 minutes. This is someone that they've been working on getting off the street for a while. And so that's just the reality of how things function. And so to say, well, they're gonna be discharged, where are they being discharged to? The reality is that they might very well be back in our neighborhood, on our streets. And so one of the things I've been urging the district attorney's office and the Midtown Community Court to work on with us is not to constantly keep referring people to programs that bring them back into this neighborhood. Because we have serious issues with narcotic activity, with mental health issues in the unhoused. And when you say, we'll take referrals from the neighborhood, I don't know the name of the guy who walks down the street, no pants on and no shoes on, but I see him often enough. I can't identify him. How do I, so what are we gonna do about that? What is the reality of how you're gonna function within our neighborhood?
So let me try to focus some of that.
Yeah.
Brian gave a clear present about our daily stuff, right? The specific things in a committee like this, we would ask, right? Which we asked and engaged with the Watson on 57th Street. So first, is there smoking in this building allowed?
No.
Okay, you must provide a place somewhere for people to smoke. That was a huge issue with the Watson. Once we had them provide a place for people to smoke, there's a whole help on the surrounding neighborhood. People, designated areas somewhere outside, wherever it is, you gotta figure it out, right? Second, that happened also was a big issue on West 52nd Street. Remember, once we got to open like a tourist thing in that building, then all of a sudden it was much easier for the ladies to engage. Bicycles, right? If people are employed or engaging with messenger services, or maybe you've got to figure out a way for that too, so we don't end up with the huge issue with the Watson. You probably remember, this particular committee voted, we recommended to put bicycle parking, and it turned into a nightmare. So you gotta throw out bicycles, right? These are the kinds of things that'll be no less, right? Next one is.
Sure, I just will say, I'm not sure that bicycles are gonna be the same level of issue, just because there's not the quantity of people that ride the walk.
You can have just one.
I didn't anticipate that level.
I would say.
Yeah.
Laura, you can.
We're still gonna put it in the list.
Yeah, I am, I'm trying to anticipate nothing, because you never know. Next thing is, the open spaces that we have that exist today, which are the canoe. Between on 36, between 9th and Dyer and Bell Object Park. Those are the actual ones that official park, one is run by the bid. How do we manage that if clients, patients, guests come and get engaged with people who are selling drugs, using drugs? How do we break that chain right away from your staff? The other two locations to look at for that kind of thing are the street seats on West 35th and on West 37th Street, where again, somebody could say, oh, this is a great thing to do, and you get a whole activity thing happening. It's voluntary, so people can leave. We all should know in this field, people will decompensate, it's not even a question, it's up and down. And if someone does walk out, leaves, in some of the answers, I think we're gonna ask you to sort of detail that a little bit further, right? The 12-month limit, you've already said you're flexible on as we're working through this kind of stuff, and you give us information about the tree goes to go to housing, right? And as Katie said, if it's in the process, it's one thing, but if people just keep turning it down, that's a different story entirely. So let me just note, Katie said we have shortage of supportive housing beds. I will tell you that today, in the organization I run, I have 35 open supportive housing beds that I cannot rent because the system is so broken. That we get referrals, nobody shows up. We get referrals for shared apartments, and they're for men, and it's a woman shared apartment. We get referrals for building with seniors, you get 18-year-olds. It's like, you've got to commit somehow that you're gonna work to help that part work better, so your people actually get placed. Because that is super frustrating to know there's vacant apartments sitting there. And then the last piece is this, that connects with that, is the city thefts stuff, which I don't know how this got into play during COVID. But we literally had people saying, I do not want a shared apartment, I don't want a studio. I want a one-bedroom apartment, give me my theft voucher, and they're walking around as if they're gonna find something for $1,200 a month. This is a complete broken part of a system that just clogs the whole thing up. Next is the wellness checks. So that's a really good thing that you do, but believe me, you should know, I do well, my office does wellness checks too. And certain people target it more than others. We had 3 people die in August with wellness checks. Because even with that, these things happen where people are taking drugs or there's health issues, so I would say you're gonna have even more frequency on certain clients for that, to make sure you don't end up with that. Ambulances, you have your own, call back and forth. 52nd Street, our big issue for the longest time was ambulances responding. So we're gonna put that in a letter too, because that was something we had to solve. And once that got settled, we worked on that very diligently. That helped people on block, a great deal. And then the issue you have that you don't have that DHS has is that they've modified their rules. They make a referral. The psychosocial says this person is diagnosed schizophrenic, this person is alcohol abusing, this person is drug addicted. And their new rule says, if the person denies all 3 and they say they need no treatment, you still must take them. I find that to be so sort of bizarre. It's like, you're trying to help people to get through a process. You're not trying to enable people to stay in a horrible rut of life. And I frequently had to challenge that, right? So you don't have that because you are doing an internal referral one-to-one. Maybe you need to think about how your model, if it works, can be imported to other parts. You know, I would put a 7A administrator on DHS and see if that helps. And now for medication, can someone refuse to take medication? And if they're, is that a milestone of the program, they click on them, they're fine. And then they refuse, and then they're very disruptive on the street or, you know, whatever, how do you manage that?
Yeah, I mean, that's what we're saying, so you have to meet your milestones and you have to be part of the program. If you're not, we all seems like are familiar with mental illness, if you're not taking your medications, you're not gonna be functioning for a while, so then you can be there, right? So that would be, I mean, I don't wanna say it in a simplistic way, but it would probably be.
You're able to manage that through.
Yeah.
Because again, we want success for the program, we want success for the community. And certainly, you have no open space, so if the hanging out in front, I'm assuming this is gonna be part of your good neighbor rules. Because, because if we have that, any supportive housing we have, the neighbor has, is well managed, you don't see that. The ones that are poorly managed, that's what you see, and that's what really turns people, like the shelter on 44th Street now, with the women who are, the temporary shelter we have, between 3 and 9, doing drugs, defecating in the street, I mean, like, it's unbelievable, and the provider is, the front door is where they end. Right, so that's, I mean.
Chris, I think, sorry.
I'm just trying to say, these are kinds of things we would put in a letter saying, here are our concerns moving forward.
But just to that, Chris, you said earlier something about you realized that you don't have an outdoor space. So I think what we realized, to Joe's point, is that if you need a space like for smoking and stuff, but are you saying that like that physically doesn't exist?
It's not a good space, right? We need to sort out how to make good use of it. You know, if you walk by, you'll be able to see what I'm talking about, where there's sort of a metal gate on the side, up to the sidewalk. And then there's something in the setback that's elevated, but it's hard to get to. There aren't stairs or ladder or anything to it right now. It's a very strange setup actually right there, because the gate
Don't you have a rear
on the stairs.
There's a setback in the rear too, though.
That I'm not sure. Oh, actually, I do know there is. I don't even know how to access.
So that's how we resolved that with the roof
No,
on 52nd Street. It was small, but it was at least adjacent to a treatment space, not a room. People, they're gonna smoke.
Yeah, we can look into that.
Joe, I think what we need to put in the letter also is having the ads more frequently initially.
Oh, yeah.
And I would like if we could put in the letter, what you said about the slow opening, but I think it needs to be, if we could request that it's like 3 to 4 patients, clients, guests per week. Slow, a little bit slower if we could request that. I think it's gonna be really, really important, not only for you all to demonstrate success, but it's really, really important for the communities to see that this place is doing well.
Hmm?
You want,
Yeah.
it needs to happen, especially where it's located. So I would urge you to consider
Is it a real term?
very slow.
Right, so what
You're
I,
saying 3 months, I would consider a little longer.
right, so I ticked off those things as the beginning of a letter for the committee members, just that's the general idea, Brian.
So a question, so I'm a resident or a guest, I leave the facility, is there any way to identify that this person lives there? Are they wearing a bracelet? Do they have, I know they have the ID, but there's no like medical bracelet.
No, we don't want.
Yeah.
They can choose to wear the ID outside if they want, why, which happens hurts a lot.
Yeah, I'm just, to your point, I'm sorry, Brian. So I thought the meeting's been great, the mission is fantastic, it's
Yeah.
a wonderful, wonderful thing. Then I just heard Brian talk about the neighborhood and the problems in the neighborhood, so I didn't see you guys answer his question about how you're gonna deal with your patients, guests stepping over or being involved with all the other services that are there. So how would that affect your performance, failure rate, success rate? Like, how are you gonna address that?
And your approach.
Your approach, because it seems that I haven't really been on the block, but it seems like it's a huge issue.
It's a doozy.
That could hurt your program. So how are you addressing it?
I think Joe started writing a letter, so we didn't respond.
No, sorry, no,
But I
we're at,
yeah.
that's where I'm.
So what I'd say is, from our perspective, the patients are already here, right? People are already in this community with these issues. So we are not trying to be additive. We are trying to work with the population that already exists, whether they're explicitly in
You're
this.
not actually, you're bringing people from your system, some may have been referred from this location, but they will be referred from all over the city. And that's okay, and that's fine. And we may be able during the course of it to ask you to treat or seek to assist certain people for the voluntary commitment getting to, but you're not working with a bunch of local mentally ill people in this district, because that's not what's happened, and it's okay, right?
I
And
wouldn't
that's,
make that, I wouldn't say that
that's what
outright.
you inferred just.
I think a better.
No,
response-
I'm saying I don't agree with how you.
I think a better response is, which is what I've heard from you all already in the meetings we've had internally and a little bit here today is. Well, first I would say the fact that it's being run by HHC, right, Health and Hospitals is, I am glad for. Okay, because of my experience being in this community and dealing with DHS, dealing with you all. There was a major difference when I visited the DHS site and I visited the HERP site, okay? But I think that's what you need to say, as well as you are willing to collaborate as much as possible, be as transparent as possible. You have an email, you're also gonna have a phone number, you're also gonna be listening to the CAD. You are going to be listening to Brian Weber, he lives like down the block, right? And he knows the people on the block.
But I don't know what facility they're.
Right, but the point is
Facilities.
the point is that you are so incredibly knowledgeable when it comes to this, when it comes to that area, and you know what's happening. The way in which you're doing a better job at detailing what's on that block than Joe, and you know, Joe's like an encyclopedia, right? And so, and I think thinking about those things, there's an incredible need here for what you all are doing. And you can do it well and successfully, and you are committed to that, and that is what the message needs to be. You are hearing us, that there are issues and concerns, and you will address it as it comes. And you will do the best that you can.
Sorry.
I think we should accept what we're saying.
No, I don't know, I just wanna try something, yes, I accept everything, but also I don't know, I don't wanna put words in your mouth, but I think maybe I'm hearing like a sub theme that somehow this is because this is a new program, no one has seen a program like this, I think we're trying to compare it to something we know. But I worked on inpatient for many, many years, and this is not an inpatient unit, but the staffing level is so intensive that we're seeing these people every single day, we're interacting. So I've done this work for many, many years. You know if your patient is doing drugs. You know if your patient is not taking a medication. You know so we will know these things if they're happening. And so I just want to make sure that all I'm trying to say, just to make my point, is that this is a treatment program before anything else. This is not a place where people are just living.
So call it that too.
It is, it's a treatment program, where it's not a place where we're gonna go back to our offices, let's say, you know, at Bellevue and the site is here, we're gonna be at the site with the patients, sitting with them.
It's a
24/7.
It's a location of H&H. Doing a program, that
Yeah.
location, a medical program.
Yeah.
Did Brian help you, Brian Sutton help at all with, what's happening? I'm just curious, I know we did the walkthrough with you.
Yeah.
Brian Sutton, not.
I've had conversations with Stanton about it,
And,
and he's like, yeah, you're getting hosed on this. But
I'm sorry,
this is a program that he's
did I hear you
advocating.
correctly?
That's correct.
Yes, Brian Stetton is a part of the Midtown Community Improvement Coalition, and he understands the hardships that are occurring in this neighborhood, this concentration. I don't want to speak for Brian Stetton.
Right.
Brian Stetton's in an awkward position here, because this is a program that he's advocated and believes in. But at the same time, he understands the issues with the neighborhood. So he's not gonna get in the way and interfere on this thing. This is a program he's been trying to get off
Right, I
the ground for
understand.
4 years. But, you know, what was made clear to me from the mayor's office was our electeds needed to.
Yeah, I will say again.
And the electeds in a internal meeting we had, didn't seem like they were in favor of this and going forward,
Right.
but wait, one more thing. I think the other thing that's important, given what Brian just said also, Omar, are you gonna be working on site at all? I don't recall.
Not me, not myself, no.
I don't recall, well, the point is, I was gonna suggest that also having collaborations with the other social services that are like
Yeah,
on
we started
talking
that.
here, but with the other EDs,
Yeah.
because I think there is going to be issues to Brian's
But
point,
I want to
both
just
Brian.
point out that having dealt with some of those other providers in the
We're not
neighborhood,
collaborative.
they're not collaborative.
That is not my point.
Right.
My point is not about the other orgs. My point right now is about what they need to do.
Mhm.
Okay, there are certain things that need to happen here, and we need to ensure that they do. That's it.
Yeah, and we already started that, like, we reached, we have been talking.
Yeah, I don't think there's gonna be difficulty with H&H reaching out and engaging. It's gonna be the opposite of actual follow through when someone will say, remember, Positive Health Project is the one that came and said, let's put a needle drop container on 36th and Dyer as a great location. And they came to this committee and said, there's nobody who lives over there. Probably didn't go over that well in your community relations work that you did. So I just wanna just keep on.
Yeah,
going.
one more question.
Yes.
You know, you have another one of these coming, another 50 beds. I don't know if we wanna kind of talk about in the letter, like.
Not going to be here.
If we could ask not to have it here.
You guys can put it in a letter.
should know that.
We're gonna tell you.
That in a
Yeah.
letter.
Yeah, I
You
mean,
can- you can
and-
put that.
I think, yeah, like 5th and 86, somewhere around there.
Maybe Chelsea.
Jesse?
Yeah, we're at almost 9 o'clock, and I just would like to make sure that we allow, or at least announce to anybody that is online, if they would like, they are listening, they've been here for, 2.5 hours. with
Oh,
you
you
guys.
know what, Jesse, I'm sorry, we haven't been able to see the list, but we had you close it.
I understand I just want to make sure there's six folks from the public on. I know some of them, so I know they're probably just listening.
Is there,
Like the
any- so
reps.
let's-
But if
right,
there's
so
anybody
let's-
from the public that would like to comment or has a
Okay.
question,
No, but open it, I don't see it.
they should.
So on the attendees from the public, is there anyone who wants to speak? If you do, please raise your hand. And then you'll be brought over to the panel.
Jesse, thank you for pointing that
And
out.
I'm talking to Amy Klein, Ben Lowenstein, Charles,
Jeff,
Jeff,
Judy.
Judy, or NC. Anyone?
Jeff is our neighbor, I met him earlier today.
Okay. So I see no one in the attendees raising their hand wanting to speak. On the panelists, I see just you, Jesse.
Yeah, that's just me.
Okay. So, I think, in the, notes I said before, I listed a bunch of things. We report this, but did any of the things that I listed as being part of the letter sound not correct? You know, the bicycles, the smoking, the outdoor space, the canoe. Yes, Charles.
I don't think anything sounds wrong, but I think that our letter, as well as what they need to do, is make this a bigger issue, because it almost feels sitting here that we're putting the onus on them to correct something in our community that is bigger than just what they're trying to do. Speaking to your point, it goes back to the point of advocacy, because the issue is bigger than just one treatment facility coming to the neighborhood.
I think we always frame it as the broad picture, and we'll do things like talk about there's family social services, like, I think the letter's gonna land on a point of like, the program has a lot of very good elements that we have been advocating for
And a
years.
serious need.
The serious need, the location and the way it was done, no, and by the way, let me just speak to the Brian Stetton from the mayor's office. Brian Stetton said to me that he also did not believe this was the correct location, but if it was not done during this administration, it
Right.
would not be done. That's a quote from the man who's running the mayor's office of dealing with mental health, right? So we know that this is not, it's a good program in the wrong spot, right? And the list we talked about, the voluntary discharge, all the things that Katie brought up, I'll take this from the recording. So we can just put this together, send out a draft letter people can comment on. And what I wanna note is that, remember, our board meeting is early, September 30th, not in October because of the holidays, Jewish holidays. So we have to get those comments back quickly, and we'll put it together in a bulleted form. But from what we've heard tonight in the discussion, I think it's been a very sort of balanced back and forth thing, and then some very specific things for you to engage with.
And I think you should include the quote piece that was mentioned by the mayor.
Yeah, I like that very much. The fact that she did a verbatim quote from town hall.
Especially when we talk about.
Yes, so Roberta and then Brian. Brian, what?
I think that you've hit all of the
Right.
like concerns, and I think we'll probably add to them in the letter. But I do think it's important to frame this as ultimately whether or not this is the right location. It is happening and we want it to be successful.
Absolutely.
And I want to be partners in that.
We're all over being
Yeah.
pissed from the summer.
Yeah.
Listen, we walked around on a hot day and I swear by God, we almost got smacked by a couple of guys, okay? So that's not gonna go away.
Okay, but is there a tour that's being organized? Is that what
No,
it is?
we're doing a tour of the facility. Jesse's working on the dates.
And then you'll let everybody on the committee know?
Yeah, he's back. Did he,
Right.
so, yeah, did he, or did he settle on these?
It's Tuesday, it's the 9th. It's the 9th at 9:15.
Okay, there we go. So we have a time.
But I wanna say, we were specific when working with Jesse to invite chairs.
Yeah.
If we were talking about committee members,
It
I
won't be a guess,
understand.
won't be across cast of thousands, trust me. Won't be.
Yeah.
Yeah, and the more people see something, the better it is to engage, yeah.
So,
Brian,
so I'm not overly pissed, but Carl had the benefit of my rat-free meeting.
I did notice outside.
It wasn't too bad. I just have a follow-up question about individuals in this program. I know they've been stabilized. Here are the request, or I don't know if it's a request, but some of the individuals that land up in your program that are voluntarily committed, and sometimes that are taken off the street, are there because they've engaged in violent activity. Will there be individuals with violent past, albeit maybe they weren't medicated and that led to their outburst, eligible to be in this program? Because that's a concern. Do the individuals in the program have past of felony assault or any level of violence? And I know that's most probably a third rail question to ask, but
It's not disqualifying
Yeah.
if there's something in the past in that way, right?
If people are address restricted though, they will not be in this.
That's an important one too, yes, because we had that.
Yeah. What's that mean, address restricted?
Yes.
Yeah.
Go ahead, Jeff.
Well, there are people.
I'm with you. What is address?
What is address?
There are people who have,
Like sex offenders?
Sex offenders, right? And I actually, I'm not joking. At least I did, was they have to sign waivers and stuff, all kind of stuff. Had DHS say you have to take them anyway. I'm like, they are sex offenders that we, by law, cannot put into a certain location. And it's fascinating that the agencies don't even talk among themselves to understand what it is. So if there is someone who's actually restricted being a sex offender.
Yeah, there are certain types of crimes they've been convicted of that would restrict where they would be able to live.
And I would just say that
Because we have the nursery school on 35th.
I just.
In general.
I know, but I'm saying in terms of
Yeah.
your radius of restriction.
Joe, I just want to say, hospitals, like, you guys are gonna have the opportunity to decide who you think is appropriate.
Exactly.
And so what I'm gonna ask as a huge favor. Is to look into that.
But
And
we want that more than you do.
I know,
We
want
don't
it to
want
be
that, but
successful.
in this space,
I understand.
they're gonna make the, but why would we do that? You know what I mean? So we want the same thing that you want, honestly, because we want the program to succeed.
Should I start this letter by saying they're not DHS?
No,
It's your letter, Joe.
it's.
I'm really saying, I say that officially, to make the point, remember, this committee, how many? Do we review, guys, how many shelters, 15? 14? 18? Something like that, they just got running, so, and they were all managed in a wide range of ways. So let me ask now for, is there general consensus that Brian, is there general consensus on this? Of the things we've listed as a basis for letters?
Read the letter.
And then we'll send out that to be looked at carefully.
Yeah.
Second by,
Oh.
yes, all those in favor of writing this letter with those items?
So
Anyone
I can't-
opposed?
I can't count, so someone in the room needs to be counting if there's any opposition, so just.
I know, I'm going to. All those in favor, raise your hands again. All those against? All those present not eligible, all those abstaining. So it's 100% in favor, and we look forward to working over email on getting all these things together. I want to thank you so much for coming tonight, and
taking the heat.
well, it's not really heat, this was.
Not compared to last time.
It was someone else that you had to deal with.
Can I just say, trust me, this was not a heated situation. There have been many things here that have been very, very heated, because I think we start with the fact that the facilities we manage have been such a cutthroat.
Yeah, and we're happy that we've been able to work with you guys before. So
So thank you so much.
So guys, that's it.
Yes, before you leave.
Keep it one best, like you exceed our expectations.
So, we have, it is impossible at this time, Maria, at 9 to deal with budget access.
We can give a brief overview of.
Yeah, I think we can start by
Yeah.
just setting ourselves up for October.
That's what I would say, yeah.
Also, should we can allow our guests. to
Oh,
talk.
please.
Thank you.
Chris, I think we're staying at your place.
Thank you.
Okay, Roberta, take it away.
Yeah.
Thank you for that. Oh.
I'm gonna.
I can say. Everything that's saying. Yeah, why don't you put your number and I'll, or email address.
So we are, one of the items this evening was to discuss the budget asks that will eventually go into the statement of district needs from the community board. I think Jessica described this last night, but the charter mandates that community.
Move it down the hallway, please. Fine.
Yes, it feels like the projector is creating heat, it's very weird.
No, the AC goes off.
So it's like, there's heat emanating from the projector. Okay, I'm not going to raise it. I'm so sorry, that was not what you wanted to.
Make a motion.
For those systems. Okay, so we got this, we got the budget. In theory today, we would have gone over two different spreadsheets. One of them, they're in the Dropbox folder. They are the capital and expense, and specifically the HHS tabs. Typically, what we would do is we would compile a set of like capital, which are basically like durable buildings,
Sorry, can someone let him in?
physical infrastructure. I don't think I've heard this.
Just leave it open, for now.
Yeah, probably now.
There we go.
So physical infrastructure, you know, you can Google as to what is a capital expense, or I'm happy to talk more about it. And then there are expense items that we have to budget for in any given year. This could be like street homeless outreach, it could be providing vaccinations for
An additional nurse at Ryan or something.
yeah, like salaries, for example, like so a nurse's salary. So we would normally go through these and look at last year's and see if we want to keep them. And we would, at the same time, look at all of the letters that we have passed since November of 2024. And you would go through the resolutions, you can look them on the CB4 website. and see what are we missing from that set of the resolutions that is not already in the list of capital and expense. So if I could offer recommendations for homework, which I am allowed to do, I guess.
Of course.
I mean, if you don't do it, there's nothing else. But a recommendation would be to look at the capital and look at the expense and to see if there are additional things to be added, to be removed, to be changed in priority. And then to go through and just take a look at the letters that have been written over the past year from this committee. It'd be a little hard to see which is our committee and which is another, but you can sort of look at the names of the resolutions and sort of take a guess from there. Happy to help gather all of them if that's more helpful.
Roberta,
Yeah.
sorry to interrupt. I can pull those all together, and I just didn't get a chance to do it before this meeting, but I can send that I can put all the letters in the Dropbox that are, I will make the judgment call whether they are budget,
Thank you.
budget, so that you guys can take a look at those. So that's not, don't feel like people need to do that.
Thanks, Jesse. And so we'll take a look at those. And then the final thing that I think is worth looking at is if there are things that we have not written a letter on and that are not in the previous statement of district needs. Like, is there a utility in having those people come to next month's committee so that we can either have a discussion or write a letter about that topic? And that is something that we can raise to the chairs if there is really like a gap in our in like the letters and previous items that we have looked at. I think that would be my recommendation of how to proceed. Feel free to mark up that list or write the list down. And I would say come prepared to talk about it at the next meeting. If you, I don't think we have to start this via email, but I think that would be the easiest way to proceed. And if you have questions, always happy to hear them.
Could I have one question, which is, I think Jessica said it last night, or somebody, anyway. Wouldn't it also be possible if we think that there might be an ask that we want to have included in the budget that we haven't included in a letter yet? That we could suggest that at the next meeting, vote on that just in a letter, right? Like, oh, we should allocate whatever, right, to support the night communication or whatever. If we come up with something that we think is relevant to what we've been discussing, then we could vote on it in October, and then that could be an ask that we could include in.
It would go to the budget committee to reconcile. Sure, we always do come up, yeah.
All right,
Yeah,
so that's
we
just something else I think that we should all be thinking about. Is there anything that actually isn't written anywhere that we want to advocate for so that then we can include it in our budget?
But it should be,
Something we've been discussing as a.
Right.
As a board, and usually there is some documentation or letter about it, we don't
Right.
just usually.
but there should be some, whatever your thoughts are, if it's a new idea, it should be executable.
Yeah,
It can't be,
exactly.
can't be a generalist,
Exactly.
let's end homelessness on the west side.
Right, right.
That's not.
But it needs to be something that is like,
Can I
that
add,
we propose next month.
sorry, no, can I add a little more context to that? Yeah, it's completely suitable. It's completely acceptable if you guys want to pass a letter in October at your October meeting and then also include it in your include it in your budget request. I will say though, I think each of these is unique. I think though it needs to come with some background information, like you would usually have an agency and or an advocacy organization or some type of outside expert, providing you guys some input for you guys to then make your determination on that. So I just want to be clear. I don't want to give, especially newer folks on the committee, the feeling that next month is like a free for all where you're just coming with a short list of things that you think would be important. Like they are important, but they need to come with some context and some expertise. And I'll just say this too, just because I don't want to keep on interrupting. Roberta's points are all valid. I think the other thing people should take a look at is the statement of district needs, which is this sort of the narrative, right? It's a two-parter. It's basically you're stating the need and then we're stating the request to solve that need. I think it's really helpful for the budget task force to hear from you guys if the narrative needs to be updated or changed in any way, we do that anyway. The budget task force does that anyway, but it's
Might be
really
outmoded.
if you guys, because you guys have been doing all the work on this, to say specifically this section is no longer needed, or this section needs to be updated because we just found out about a whole new program or whatever it is. And then the third thing I would just say for newer folks as well, what's also listed in those budget requests is their agency responses. I will tell you, the agency responses are not great. All right. Even, they'll tell you, oh, it's solved. And so therefore we think we should take it off our list. We could take it all off our list. That might be something you guys decide to do, which is completely fine. But I also want to be understanding that the agencies can say one thing and it doesn't get resolved.
Will be funded in existing programs.
Right. So I do want to understand that the whole document as a whole is just not a data sheet of like numbers and facts. It is a political document for you guys as a board.
Yeah.
So if there is something that is a priority that may be already funded, like I will say, you use an example, for a long time, we continued because of our neighborhood, we felt like we needed more homeless outreach workers, right? Every year they would say, oh, we funded it. It's funded. Right. But we're saying, okay, but that's simply just still not enough. So it became, for a while, it was your guys' priority to say, even though it's being funded, we still want to make this a priority. It still deserves to be in the top 5 of the, expense requests for your committee.
The Chelsea Rec Center.
Now I will shut up. I will shut up.
The Chelsea Rec Center was our #1 capital priority for 16 years because the building was never finished. And finally, after 16 years, that became funded.
I'll bring another. The Muhlenberg, as of yesterday, right? We learned the Muhlenberg branch of library is now finally open. We've had that on our ACES agenda for, I don't know, a decade. So.
I have a question. Approximately how many HHS letters do you think will be there for our review?
Yes, 1,000.
I'll be honest with you. You won't have many.
Just, yeah, November. Okay. So we don't split it up or anything.
Roberta, thank you for doing this part. First, I want to thank everybody for serious, diligent questions tonight, and really engaging with these folks. It's so simple, especially after our comments from last night. And is there a motion to adjourn?
Oh, second.
All those in favor, please say aye.
Good night, everyone.